Test, test, 1, 2, 3. Test, test, 1, 2, 3. Test 1 2.
Hey, good morning, Dorothy.
Morning. How are you?
Test 1 2, test 1 2, test 1 2.
Hey, Deb. I'm finna go into my board meeting. We're going to Zoom meeting. I'll call you when I get through. Okay. All right. Oh, go ahead. Wait a minute. Wait a minute. Go ahead. Okay. I'll call you back. All right.
on Zoom.
Good morning, everybody. The
Good morning.
Tarrant County Hospital District Finance Committee will please come to order. Thank you all for being here, those at home and those here in the room with us. Any citizens signed up to address the committee this morning? There being none, we'll move on to item 3, the CFO report from Sharon Clark. Ms. Clark.
Good morning. Making sure my audio's on, and it is. There was just one follow-up that I would like to give to the committee. At the last board meeting, we had a question about Senate Bill 1264, which is the Surprise Medical Billing Act that went into effect in January of this last year. Just so everyone knows that JPS did not actually balance bill during the period before that. So it was not a big change for us. And this bill is regarding the balance billing of patients that are out of network that are insured. So just wanted to follow up. Is there any questions on that?
Sharon, do we balance bill people that are self-pay?
So balance billing by definition is really for insured patients.
Okay.
And you bill the balance to them for the, is there a way we can close the control room door? I'm getting a lot of feedback. Thank you. So the balance billing by definition is for insured patients, and we do not accept the insurer's out-of-network payment. And we typically accept the usual and customary payment that we've received. Self-pay patients go through a totally different process.
Okay.
At time of billing, they're immediately given a 40% discount of bill charges, and we begin to try to identify a payer source, get them a payer source, and then qualify them for charity care if they meet the minimum income requirement. And I would say about 90% of our self-pay patients do immediately meet those requirements.
Great, thank you.
You're welcome. That's it. Thank you.
Before I move on to item 4, I'd like to recognize our general counsel to make an introduction for a special guest.
Thank you, Mr. Chairman. I'm pleased to have today one of our first half of the summer intern, Amanda Garza, and recently got married, Santilli, and I have to remember that she just got married. She's been with us since the middle of May and will be through the middle of July. She is the first generation in her family to attend and graduate from undergrad school. She graduated from the University of Houston, Bachelor's of Business Administration and International Business. She's in her 3rd year at law school.
Great.
And, something that Sonia and I are very proud of. She is the first recipient of Sonia and Neil Adams Endowed Scholarship for a student who wishes to pursue a career in law in either health law or education law. So we're pleased to have Amanda on board with us this summer.
Well, thank you very much for being here. Welcome. If you have any complicated questions, don't ask that guy because he doesn't know, but he does. Okay, thank you, Neil. Item 4, I want to talk about the budget process, and I'm going to ask Sharon to kind of help me here. You know, when we had our last budget, I think Dorothy and I talked, and I know Reverend Emerson and I talked, I think even DT and I talked, and there was some shared sense of disconnect or alienation for the board from the budget process. And I think it's something that sort of has evolved over many years. And if there's no blame in any direction, if I was, I'd point it at myself as much as anybody. But, budgets are more than just numbers. And, they represent the aspirations of the organization. They represent our quality goals. They represent our performance metrics, all our ambitions to maybe capitalize on industry trends. They represent a lot of things. And there's a lot of work that goes into crafting those budgets as they work up through the system. And I think historically what has happened is by the time it gets to us, all of those hard decisions and that critical thinking that went into crafting those numbers is so baked in, we don't see it. We just see the numbers. And so there's a separation there from us as seeing how these budget things come together. And this was something I wanted to do earlier on and propose to the board maybe a revision of that process to integrate us as board members more into that process of budgeting. And quite frankly, when our world got turned upside down, I took my eye off of this ball and really didn't think about it until the last few weeks. And so now we're sort of compressed up against, when we actually have to approve the budget in August. And so what I want to propose to everybody is some dates in July that we can have some half-day sessions. And one session will be director level folks coming in, presenting to the board, talking about their areas, what's new in their budget, what they've asked for, why, how that fits into our mission and our goals, and maybe get some strategic guidance or strategic input from us about those goals and how that comes. And then another session, I'm thinking like maybe 4-hour blocks or so. And then another session that we're actually crunching on the numbers or looking at the numbers, and Sharon presents that. But help us kind of get more deep into the process of how the budgets come together. What are all the departments doing? Frankly, I've been around here since the early 2000s, and I'm separated from a lot of the operational stuff. And I kind of forget what's going on. I mean, we have some healthcare professionals on the board that know the inner workings of the organization, but a lot of us are just business people that are out doing our thing. And so this is a way for us to maybe weigh in on the budget. And so that's what I want to propose to us. We picked 2 dates, 2 Fridays in July. They can be 4-hour sessions. They'll be recorded. So if you're not available, you can go back and watch. And of course, staff would be available for you to come back in and ask questions, but get some exposure to that department and that process. So I just kind of wanted to throw that out there. Sharon, did you have any finer points to put on that before we propose it to the board?
No, I think kind of bring back some of the dialogue with the vice president, understanding kind of a basic purview of what people's organization looks like within JPS. We don't have the ability, just based on a time restriction during the actual budget presentation, to get into operations or what we're doing in quality. And we're trying to go back and incorporate some of those comments that I've gotten from last year, and get everyone geared up and ready to hear the numbers. So any other comments that people have, we can try to incorporate, and Steve and I will work together to make sure that that's brought sometime in that 2 half-day period.
So as I propose this, does this sound acceptable to folks? Any kind of tweaking on it?
Steve, this is Reverend Emerson.
Yes, sir.
I have a question for Sharon. Can you qualify for me what you mean by we don't have the time to deal with quality and operational? What do you mean when you say that?
So when we're in the actual budget presentation, that is, it's a good 2 to 3 hour presentation. So for us to bring in discussions at a vice president level or more of an operational focus, that would have to be a couple of days worth of presentation. So by breaking this up into 3 days, the first day we can refamiliarize the board on the operational aspects and who's doing what. It's been a while since you guys have been able to see some of our administration at these board meetings, even though they've been virtual. We're getting better at it. And then the next session, we will focus on the actual process, and kind of, we've got some new board members. We've done that in the past, but for me to go through and kind of re-explain how prioritizations are done, who all is involved in those. The budget is not a finance, it's a finance product, but it's not necessarily finance driven. There's operational input throughout the process. Dr. Hochberg, Dr. Duncan, myself, and Robert Early work very closely together and coordinate that process. So it's not me driving the decisions. We have committees, we have physicians that are involved, and trying to prioritize those new items that may or may not be funded in the 21 budget. And then during that final presentation, I think that will give you guys kind of a soft landing into some of the new items that may be included and some of the bigger changes. So it's kind of a step 1, 2, and then the final third where we go and ask for approval from the board.
Okay, so Steve said 2, but I heard you say three meetings. So are we?
Well, the third meeting is the actual meeting that's already scheduled on August 13th. It's a normal board meeting where we will be asking approval for that budget.
All right, okay. Okay.
And they're optional. And again, they would be recorded so people could go back and look if they can attend those days. I think it'd be hard to get us all in the room for 2 days at the same time.
Well, Steve, I think it's a good idea. I like that.
Okay.
That will give us more information about what's going in the budget as it's being developed. And
Exactly.
then any new projects and stuff. And that will give us time to do some input if we have any. Yeah,
Exactly.
I like that. Okay.
Okay. Thank you. Anyone else have any ideas about
Good
this?
idea, Steve.
Okay.
Steve,
great.
Steve, you know what dates you're talking about?
I think we're looking at the 17th and the 24th.
Correct.
They're Fridays. So
It's not like everybody's got a whole huge amount of vacation plans. So it might work out fairly well.
For yourself.
Yeah, maybe y'all are going on vacation. You just didn't tell us. I get it.
Well,
yeah.
My I don't know what my dates are, but I have to do a state to the presentation to the TEA in July. I just don't know what those dates are at this point.
Okay.
And I'll have to just get back to you. I'll find that out today and get back to you on that.
Okay, great.
What we'll do, Reverend, is we'll have Suzanne, with your permission, Steve, we'll have Suzanne sort of float those dates. And if there's huge conflict, then obviously we'll look at 2 other dates for that. But if we get many of you all available during that time period, and then to Steve's point, we're going to do it on 2 Fridays, hopefully we'll encompass everybody during those 2 days. So we'll float those dates out. We'll have Suzanne get that out to you all and make sure that it doesn't conflict and everybody's going to be gone.
Okay. Great. Thank you all. So let's move on, and that there's no more comments, let's move on to item 5. 5A. Ms. Clark, the May financials.
All right. If you looked at the April financials and compared the May financials to that, it looks a lot to be the same. I think April and May were truly impacted by COVID. Some of the bigger changes I will go through or I'll point out as we go through some of the statistics, but the key indicator slides that I'll cover first, and if I can go ahead and get that brought up, I think that really tells the story of the patient flows in and out of the medical center in the outpatient arena. The next slide will be the admissions by month. Just again, visually, the blue bars are the current year and the red line is where we expected to be on budget. So you can see the big impact that began in April and May. For May, we're about 8% down at admissions. We have refocused on getting folks out of the medical center as quickly as possible. So when you look at our length of stay at the bottom right, it is about 10% down for the month. So we are actively discharging patients to limit their exposure and to also create that throughput in case we do see a slight surge. Our case mix, as was the story for April, is extremely high down at the bottom left. The case mix index actually reflects the acuity of the patients and how sick they are based on their coding at discharge. So this is a measure to tell us that the patients that were admitted, even though we had fewer patients admitted, were much sicker than they typically had been. And then when you look at the length of stay, the case mix and the length of stay are usually correlated, but because of those additional efforts that we've been using for the last few months, we've been able to actually decrease the length of stay as we move through. Next slide, please. Our emergency room has seen a slight recovery from the decrease in April. We're not back up to normal levels, as you can see. We were a little bit more than 20% below the budgeted level. And urgent care, their recovery has not been as quick. They are still about half of their normal budgeted volume. And you'll see this when we get to the right side of the page. Our primary care is still about 80% normal visits. In the specialty care, because of the COVID restrictions, are about 70% below normal levels. Now, when you look at these primary and specialty care numbers, please also realize that's about a 36,000 visit decline for just this month. However, because of the efforts that we've been able to conduct telephonic as well as telehealth video type visits, we have been able to contact patients, and we've had about 28,000 of those visits in the month of May. So there was a lot of effort that was pushed back. So patients are able to still talk to their physician. They're able to get those needed prescription refills. It could be a wellness check. It could also be a sick visit. So our primary care and specialty care providers, like the rest of us, have gotten a lot of new skills through video chats and conferences and secure patient contact. So I did want to add that to this slide. And I have a feeling that in the future, we're going to be working during the budget process to try to figure out where exactly those telehealth visits fall. Might be a separate graph, but right now they're not included in the clinic visits the way that they're captured. So there is an offset to this decline. Dr. Weber, did you have a question?
No.
Okay, I just saw your name pop up.
Telehealth is going to be a real challenge.
It will.
Yeah. So just reiterating, Sharon, on here, the April and May, we launched telehealth when again?
So there's three kind of categorical differences in telehealth. Early on, we were able to begin answering questions and filling prescriptions through MyChart, which is an Epic product. It's a secure way to go out and contact a physician. Then we were able to stand up a telephonic visit, which was scheduled. And then later in April, we were able to actually do more of a video conference. And the video conferences can be scheduled, or they can be what you would consider kind of urgent care, as you have a problem in the morning, you want to talk to a physician, and you can dial in. So there's several types of that contact that makes up those 28,000 visits.
When did we start with the telephonic and MyChart?
almost immediately.
Okay. And do we still have the number of individual patients that are utilizing my chart? Is there a percentage utilization?
I don't have that today, but we can easily provide that for you.
Okay. Yes, that was the percentage utilization for patients using my chart.
Thank you.
Next slide. So when you start to look at surgeries, which sit at the bottom of the page, you can see that the inpatient surgeries are about 12% down, a little higher than last month. And our outpatient surgeries are still about 60% under budget. We had opened up what we called a phase 1, bringing back in patients we knew that would not be requiring an overnight stay, that would be relatively easy to get in and out of the facility. We've talked to you about that from a medical standpoint and how those patients were selected, but that's a very slow ramp up for us. Next slide. The mental health component of our provision of care has, it is not impacted by, the inpatient side is not impacted by COVID. You can see that our inpatient days for mental health were right on, they have been pretty steady. We did see a slight decline this month. It was down about 15%. Our clinic visits at the right top of the page are down as well, similar to April. You can see that they follow the trend of the specialty and primary care clinics. Our PEC, the emergency mental health access point at the bottom left, was actually about 35% higher than budget. You can see that it did slow down a little bit in April from the trend, but it is back up. Next slide, please. So our days cash on hand, there's been a couple of increases of cash that we've been able to sustain, and the blue bars are not following the prior year trends. There's two major reasons for that. We had in April recorded both an $8.1 million receipt of cash from the CARES Act and the Provider Relief Fund. And then we also, Medicare gave facilities the opportunity to effectively kind of get a pool of cash that equaled about 6 months of our normalized Medicare payments. For us, that was about $49.5 million, and that was also received in April. So we talked about in April, and we talked about that last month. If you look at our net AR days, it slightly had an uptick, but I do feel like there's a few explainable reasons for that. It does not raise any large concerns for me at this point, but the payers have slowed down their payments a bit. It takes us a couple of days longer during this COVID crisis to receive some of those payments. And also there is a denominator effect just from the falling revenues. So our denominator is lower, which is causing that calculation to show a slight uptick. Our FTEs per adjusted patient day at the bottom right have been unfavorable. This is a year-to-date calculation. Again, the denominator is driven by our patient volume. And so as volumes fall, the indicator will increase. Next page, please. This is our payer mix. It's not changing significantly. We have in the last couple of months seen an uptick in some insured payments, but From a year-to-date perspective, that has not been a big change. Next slide. This is our connection enrollment. We put a couple of things in place during COVID back in March that as people apply and they get approved, they actually have a 12-month period of eligibility. So they will have coverage effectively for 12 full months. For those that have expired in March, April, May, and we've extended that to June and July, that if you come to the end of that 12 months, you're automatically renewed for 90 days. This helps sustain the new applications that we're receiving, as well as protects that social distancing as well. I don't think you're on. Oh, there you go.
Y'all can hear me. Some questions have come up about eligibility and about the impact of stimulus dollars and extra unemployment benefits and how that impacts eligibility. Could you expand upon that a little bit?
You bet. For patients that are currently a connection member, they're not getting reevaluated. So those are fine. They're continuing that. For new applicants, we have excluded both the $1,200 stimulus money as well as any extra unemployment benefits from the criteria of evaluation. So because that's a temporary payment, those have been excluded from the income evaluation, correct?
Okay.
They are not.
Okay. I would check with your evaluation staff or your enrollment staff to make sure that that information is trickling down to them, because I have received some community concerns that their utilization and renewals are not being allowed with those particular payments.
Okay, there are several criteria. If we can talk offline, and
Yeah.
I can validate that, but that is the current evaluation tools that we are using criteria wise.
Mm-hmm. So just to clarify, the renewal of the connections patients who had to renew in March, April, May were extended to June or July?
It's a 90-day extension of their current benefit.
Okay.
So we are getting to the point where you may be eligible. If you expired in March, you may be eligible for 2 extension periods.
Okay. And so for new applicants, their application is being reviewed, and how long is it before they're being notified?
I can double check on that, but as long as a lot of the delays are created from my experience on the lack of information. They do have to provide some documentation, but as soon as we get that documentation, it's a day or 2 turnaround. And we do retroactively grant the coverage. So if they're applying because they've been in network, or we have been working with them trying to find them coverage and they don't have any, that evaluation is done fairly quickly, and it would cover any prior services.
And how far is that retroactive?
I believe that is either 30 or 60 days. We have mirrored the Medicaid retroactive status.
Okay, great. And prior to COVID, we had suggested bringing somebody in from Connections Enrollment to talk to us or to do a presentation for us. Maybe now we can put that back on board.
You bet. Michelle Haynes is our director over that area. And she does give periodic presentations through Finance Committee. So we'll get her back on.
Thank you.
Next slide. So for May, kind of dropping to the bottom line, our income from operations was favorable to budget. We ended the month at about $6.4 million. About $2.5 million ahead of our budget. we did have declined patient revenues that were impacted mainly by volumes. You can see that we were $4.7 million under our net patient service revenue. That is the cash that we expect to collect from the activity that occurred in May. So that is down. We also have had an adjustment to our tax revenue of about $770,000. This is due to appeals that have occurred within Tarrant County for property owners that have resulted in lower assessed value. So that was also an impact, and we just went ahead and recorded it in this month. If you look down at salaries, at total expenses, you can see that even though we had an underage of about $5.5 million in revenue, the $8 million of savings that we had in expenses more than offset that decline in collections. So salaries and related expenses were actually over. Most of that occurred in the benefit category. Our pension expense, because of some of the current market conditions, was above our budgeted amount by about $2 million. So that was a big impact for this month, as well as our health insurance was actually under. If you can relate the access points from our patients, our employees are also accessing less health care. So the decreased employee health was offsetting to that increase one time in our pension expense.
Is pent-up demand that may occur later.
Right. So if you drop down to our purchase service, and as Steve pointed out, we have a large decrease in some of our purchase service expense because of claims expense that we pay on behalf of those connection patients on the prior slide. What does worry us as an organization, and it also impacts the employee health, is these are probably not true savings for the rest of the year. We will eventually start to have lifted restrictions, and we will have the ability to see more patients, which will increase these expenses. And there is going to be a component of pent-up demand. It just depends on how quickly organizations are able to reopen. So although we do have a savings of expenses, we don't know if that's going to be a life-to-date savings, a permanent savings, what portion of that is going to be permanent versus which portion is going to be felt in a later month. We're not able to accrue those because they have not been incurred. So we'll have to record those in the month that they happen. Also creating some savings is in the supply category. Even though we've had to pay some extraordinary pricing for PPE, that is more than offset by some of the implant savings that we have, some of the drug cost savings that we have for some of the decreased surgical and inpatient volumes that we've been experiencing. If you look at the right side of the page, this is our year-to-date income statement. And we are still ahead of our budget at $51.1 million compared to a budget of $41.5 million. Any questions? Okay, next slide. And if we can skip two more to the graph page, thank you. So this is a claim activity for the month. You can see that billed encounters are down in a claim as well. And I do typically point out the net operating expense per encounter at the bottom right. Again, because encounters are down and the denominator is starting to decrease, the cost per encounter is rising. Next slide, please. Next slide. So for the income in May, a claim does not have the ability to decrease their expenses like the medical center does. As you can see, most of the expenses are provider salaries at the top of the page. Our net patient service revenue is down by about 2.4 million. And then you can see that our expenses are down by only about 620,000. Now, these are the providers that are doing the bulk of the telehealth, telephonic, and MyChart visits. So they are still seeing patients. It's just seeing them in a very different way. That created a gap from our budget of 2.2 million loss to just over a $4 million loss for the month. Year to date, that has compounded over the last several months, and we are at a $25.4 million loss compared to a budgeted loss of 17.1. Next slide, please. When you look at it from a consolidated basis, we always look at, I'm going to kind of talk about the year-to-date numbers. These columns represent what I just showed you on the medical center, a claim, and we can't forget our foundation. If you scan down about halfway down those numbers, the income from operations from a combined standpoint is 27.2 million. We budgeted to be at 24.9 million, so we are on track or just slightly ahead, about 2 million ahead on that budget goal on a combined basis. So it's very important from the ability to continue forward as a organization for that combined number to be self-funding, and indeed we still are self-funding and have also hit that budget goal. So to me, that's a really important summary slide. And that is all my prepared comments unless someone has some questions.
Any questions for Ms. Clark?
If I may. Actually, this is DT.
Yes, the delegate from Colleyville.
I guess I took a different view than Sharon on the booking of the CARE Act. And I think we booked it as what you call the right word for it, the other income revenue. For me, I view that as debt at this point until we legally having a piece of paper that we fulfill all the obligations for the debt release, then it can be reclassified. And to me, when it reclassified, it should be reclassified as debt forgiveness or as a grant rather than with a footnote, because otherwise it will be viewed as we earned those revenue, which we did not. Those are grant. And we can reference to the FASB accounting, GAAP accounting, SASB ASC 405-20-40-1B for reference if we need to.
So DT, I'm going to repeat your question. So I don't know how well you're coming across and for everyone, but the question is kind of basically how we have recorded the 8.1 million of the provider relief fund, which was the original $50 billion that was provided by the CARES Act, and the 49.5 million for the Medicare advance payment. And I'll address each one of those differently because they're treated differently on our income statement. Also, there are so many components of the CARES Act and how these funds are flowing right now. We have been in close contact and have followed the advisement of BKD, our external auditor, so that these have been recorded. Did you have a comment?
No, I
Okay.
lost you, Sharon. I couldn't hear you.
Oh, okay. Where did you lose me?
No, about 2 sentences ago.
Okay. So we have been in very close contact with both with BKD, who is our external auditor. And these two amounts have been treated very differently. So we did want to make sure that the generally accepted accounting principles, or GAAP, was followed. The 8.1 million is recorded in our other operating revenue based on those conversations with BKD. We do not, and I can go back and double check with BKD on your concerns for repayment, but that is where, after their studying of GAAP, they have been advising their clients to record it there. The 49.5 million for Medicare advance funding is recorded as a liability on our balance sheet. It has not been recorded as income. It effectively is a cash advance, and we had that cash advance from March till September. In September, Medicare will continue to process our claims, but instead of sending us a wire, we will be pulling it out of that advance payment of 49.5. And so as we process Medicare patients through our system, we'll be able to recognize that as normal patient revenue.
We received the letter from the I guess Department of Treasury, or whatever the department that overseeing the CARE Act, that we fulfill the obligation, and the 8.1 million, or portion of that, is complete, and we are no longer obligated on the debt, because I think by the time the final report for us, we may probably receive that letter, but until we have that letter in our hand, I don't think we should treat it anything differently than the debt, because to me it's not operating revenue at all. If anything, it's a grant. And I would love to see.
Remember that grants are also operating revenue, and included in that other operating revenue line item in our financial statements on a normal basis. That's where we record grant revenue.
Right, only when you have a footnote, though, that to specify that. And I would love to understand more, to see which FASB, they reference to from the general GAAP accounting. Because there are a few of them, the FASB ASC section 470, or the 1405-20-40, or the 835-30-15-3. They all very specifically said these are dead, and it may change. The government may change it down the road, but we should. I think we should follow a very conservative approach. In that regard, it won't affect your cash flow at all, but I just disagree with the booking at this point.
So noted, and understand that we don't provide footnotes for interim financial statements. And by the time we get to September 30th, I'm sure that there will be a lot of footnotes regarding the COVID dollars and how those are recorded and disclosed for our external reporting. We will also have the opportunity to reevaluate, but regardless of how we record these on an interim basis, the reason that we have been in close contact with BKD is that we don't want to have a change or a difference between our interim financial statements and the audited financial statements. So based on our conversations as late as last week, this is how BKD will be treating the disclosures and the recording of those funds.
Yeah,
So I'll be happy to get Chris Clark on the phone with the both of us so that we can be comfortable with the way that the interim statements are being presented.
actually, if she can write, if she can give us a assessment, or I forgot the terminology, when you get advice from an attorney or an accounting firm, so that they can give us that their point of view rather than discussion, because it can get lost for me and other board member doing translation type thing like that. But for me, it's more than that, because I agree that we don't have footnote on an interim one, but we also have responsibility that when we look at bonuses and other stuff, grant, debt, and all that stuff for consideration, because we have to go through a few more exercise referencing some of the performance and all that stuff, and that is something that you can't take the money that you get grant or debt and throw bonuses on top of those things. That would be responsible for us as board member type thing. So that was my biggest challenge. It won't change any of the cash flow or anything like that. I can't. But for me, it's important for us to categorize them in our mind so that we know, regardless we have to do it or not, for us to know that, hey, there's a footnote here for us when we look at the financial.
Right, and we will, I hope you feel like we've been completely transparent with the recording of these numbers, and I will continue to remind the committee exactly where these unusual funds are recorded. But generally accepted accounting principles are totally separate from a calculation like you were talking about that's an internal calculation. So we'll continue to talk, but I will get a written opinion letter from BKD. They have that from a firm-wide standpoint, so all their clients are treated consistently. And they also have reasoning behind why they feel like it's categorized correctly. And then I'll schedule a call to just to follow up.
Okay, and then the one that I'm referencing to the accounting consideration, I'll send it to you guys for note-taking type thing, so that you guys can look at that also as well. So I'll follow up and I'll send it to Suzanne, the chair. Thank you.
Thank you, DT.
Steve, I have one question for Sharon.
Yes, ma'am.
Sharon, in the overall hospital summary, there is a reference about a 7% updated calculation for the pension expense. Is that just our routine update that we do once a year?
Yes,
that has
ma'am.
nothing to do with what we just did, right?
It does not.
Oh, okay.
It does not. It kind of solidifies perhaps the reasoning behind what we did as far as limiting to new entrants. But we have a once a year actuarial study where they calculate both the expense side of our pension as well as the funding side of our pension. So we did have quite a large increase in the expense side, which is what I talked about when I covered benefits on the income statement.
Okay. All right. That was my only question. All right. Thank you.
It's a good question. Thank you.
Any other questions for Sharon?
I have one, Steve.
Yes, sir.
If I may. I was wondering if we are receiving any type of compensation from the federal prison folks for the people that we're taking in.
We have a contract with the federal prison, and they pay us for the inmates that come here, and they pay very fair. So that's a contract that we've always had set up with them, whether they're coming in for COVID-19 or they're coming in from any other situation. And we are their hospital of choice contractually. So they do pay us for every patient that comes in.
This is the male prison, correct?
Yes, sir. It's the male federal prison and the women's prison as well. We have a contractual relationship with them as well. So both federal facilities here in Tarrant County, we have a contractual paying source from them, and that's always worked out very well.
Yeah, just curious. I guess I missed that. I thought we did not.
No, that contract's been in place for a long time. In fact, that predates us.
Yeah, it predates me even back to 2001. Yeah, it's been a long time. Steve, yeah, it's been there a long time. We've updated it periodically when that term expires.
Great, thank you.
Okay. Any other questions for Sharon? Okay. Counselor, you might have to remind me how we do a vote on this.
Vote to accept the financials as presented.
Okay.
You need a motion to that effect.
Okay. Entertain a motion for approval of the financials as presented by Ms. Clark.
Approval, it's acceptance.
Acceptance. Yeah, I'm sorry.
Yeah.
Acceptance of it. Motion by Dr. Ziegler, a second
I'll second it.
by Dr. Weber. All in favor, please say aye.
Aye.
Any opposed?
DT,
Motion.
because of that question.
Okay, so you're voting no on this?
Yes, sir.
So we have all yeses, one no, DT Win, no. Please note, Leanne. Okay. Okay, thank you. The motion passes. We'll move on to item B.
Generally accepted accounting principles as well. I'm going to start with a little bit of history. As a claim was developed and is a wholly owned subsidiary of the hospital, there's a lot of intercompany transactions that happen. We know that a claim is not going to be self-funding. So every month there are a lot of transactions that go back and forth, but it all results as a net receivable from a claim on the medical center financial statements. When we consolidate financial statements, the receivable is taken off the medical center, the liability is taken off of a claim, and it nets to zero because from a consolidated basis, they try to remove all those intercompany transactions. But in the required communication every year that Chris talks about, Chris Clark, and the significant matters discussed with management, for the last 3 years, we have had a comment on the intercompany payable and receivables between a claim and JPS. From an accounting standpoint, at the very back of the audit, there is a consolidating schedule where each one of these companies is presented individually, much like the last page of the report that I just covered. When you look at the standalone medical center column, BKD's concern, which is very common for hospitals that are owning 501As, much like a claim, is that the parent company does not really intend to have that amount paid back to them. It is viewed more as an investment or an equity transfer to support the function of that entity. So this motion will actually, and the wording of it was important. It was to forgive the debt of the Acclaim Group owed to the hospital district as of September 30th of 2020. There is no cash transaction or business transaction that will come from this resolution. It is simply a resolution that will allow us from an accounting standpoint to include that amount in our equity as an investment versus a receivable that is expected from a related party entity. So that's, I'm going to stop there and take questions or concerns that any member may have.
Any questions for Sharon?
I do. I mean, I
Yes,
guess
ma'am.
This is just supposed to be a paper. I guess I'm missing. I missed that ending part of your explanation. Maybe you could go over that again. I'm trying to figure out why we would need this now with it's no dollars, you're saying.
Correct. It is simply an accounting disclosure. When you look at the consolidating schedule at the very back of the audit, the BKD audit, we split the medical center column and the column that shows a claim. And so right now, if a user of the financials looks at the medical center column, it's showing an amount due from a claim buried in the numbers and has inflated a receivable number. We don't really expect payment back from a claim. And so BKD thinks the more appropriate presentation is down in the equity section, much like if you made an investment. So this resolution allows us from an accounting perspective to reclass that receivable from a claim into a fund balance on the medical center as an investment within a wholly owned subsidiary, which is a claim. So it's truly a GAAP presentation, but the way that that is appropriate is that the board has to recognize the forgiveness of debt, and then we will be able to recognize it as an investment. So to your point, and again, this will not create any additional transfers of cash to a claim. It's simply a presentation on the final BKD report.
So the forgiveness of debt, is that already what we are showing as their loss?
It is. It's a cumulative amount over the last 5 years, and every year it grows. It's a cumulative amount of their their life to date losses. So 5 years worth.
Okay.
The amount currently that we're carrying is about $86 million. If you look at this year, it's about $15 million a year.
Okay.
And one thing, Dorothy, this is also coming as a recommendation from PGAD and Chris Clark.
Understand it's coming as a recommendation. I'm just trying to make sure that I understand that, and that if when I'm looking at that report, and maybe that's part of it, I haven't been looking. I'll go back and pull that report, but I don't see that in that report. So maybe that would be something that needed to be highlighted to us, because I'm just seeing it. Yeah, you're saying this is what we put in, and it's every year. It's a cumulative number, and it's showing that's the debt that they have. We know they're not going to be paid, and it's going to be recorded in another accounting way. Is that the
Exactly. It's going to be recorded as an equity transfer and not an account receivable.
Okay.
On the medical center side.
And with this resolution, will we have to do this annually, or is this a resolution that will just continue on?
The resolution itself can be modified to allow us to adopt this method of accounting, and you won't have to approve it every year. The way that it's written now would allow us to do that.
Does this change the a bond rating or our obligation type thing? Because one is treated as an obligation from a debt that, from a liquidity standpoint, and now investment.
That's a great question, BT. I do not anticipate any change of the bond rating. When I talk to the rating agencies, they are actually looking more at our combined entities. They are not just evaluating the medical center. A claim is a large part of our discussion, and they already see that as a big group of one. So we are reviewing the medical center, a claim, as well as the foundation when I talk to either S&P or Moody's.
So in the consolidated world, it's a wash, or it doesn't.
It is.
Okay.
But should we consider that as a loss of operation rather than investment into another outfit? Because it's going to continue to have loss and losses every year.
Conceptually, I understand your point, but from an accounting methodology, that it's defined as accounting for it as an equity transfer. since we are seen as a related entity and because a claim is closely held and fully owned by the medical center, that is the accounting treatment that's required from this type of funding.
But should we consider that as part of the professional purchase type thing? Because it's an ongoing loss. So if we say it's an investment, we are not actually consider that as a total cost of care versus the other one's total cost of care. You see that as a loss as an investment, so that we can increase that side of it, but we actually decrease, on the quest of decreasing the cost of spent at the hospital to keep them away from the actual hospital and for wellness program. So it's a shifting of the care part versus they perceive as an investment to an entity that may have some future value in the future. That's my question on that.
So the reason that I always try to focus everybody on the consolidated and the combined number and the importance of that is because the treatment, the accounting treatment that we are giving the 501A, which is a claim, as a hospital-owned physician practice is appropriate. Most 501As do run at a loss per provider, and we talk about those numbers during the budget process, and we try to evaluate whether we are operating effectively as the 501A. So I would say that the accounting treatment that we are using is appropriate for our situation at this point in time with a claim and the medical center.
I think maybe it's maybe I just don't get that, because one for me is when you say investment into that group, then it has a perceived valuation component that this one is an investment that will turn into a good for later, for future, if we want to sell that division. But an investment to keep the thing ongoing, should that be classified as professional services? That's what I meant.
Again, based on the 501A component and the fact that it is a wholly owned subsidiary, we are accounting correctly for our ownership in the 501A.
I have one question on a claim. On some of the stuff, they have some services that's totally a claim. How does that tie into that? I mean, are we saying if they have a business, I don't have my book in front of me right now, but there are some things that a claim bill for, some of the stuff you bill for on the other side.
Correct.
Those that they are billing for, how do you separate those losses from what you're going to say this is a, if they have losses, how will that be separated out? Are we picking that cost up?
Can I also add on? Can I also add on to that before you answer also as well? Because when you said an investment, and I'm not sure this one will classify as something that you can put on the cost report. So when you put that in investment, can you capture that on the cost report also as well?
Again, this is not going to change any treatment to date. It's not a cost report impact. This is simply a reflection of the audited financial statements and the way that it is shown. If for some reason the board is not comfortable with it at this point in time, we can delay the motion. We're going to likely see another comment from BKD and its required communication. And Dorothy, as you start to look for that, it's a separate report apart from the audit. It's where we go through management estimates and the opinions kind of behind the public document.
So
Dorothy, we kind of lost you, I think.
We lost you.
You have been unmuted. Okay, can you hear me now?
Yes.
Okay, is that something that we normally get in that report? Because maybe I've just missed it, but maybe it could be highlighted. And what I would like to do is for you to educate me a little bit more on that before I approve it. That's what I'm struggling with, okay?
We can do that.
All right.
Thank you.
So based on that, why don't we put this on hold? Because there's lots of outstanding questions. If everyone's okay with that, it's not urgent. It's just a set of accounting notation. So, all right, is that acceptable to everybody? We just put this on hold.
Yes, sir.
Okay. All right. Let's move to item C, please.
Item C is a contract with Spivey Health Policy. It is an annual cost of $225,000. It's also a 3-year contract with a 30-day no-cause term. Mike Spivey provides us with advice and guidance on many issues surrounding any supplemental funding issues that we may have and need advice on. This relates to the DSRIP program, the URIP program, how we set that up. Also, any kind of UC questions that we have. And we see him as the subject matter expert on a lot of these issues. Again, this is a $225,000 annual contract that we are asking for your approval.
Any questions for Sharon on this item? There being none, I'll entertain a motion for approval.
Move approval.
Second.
Motion by Mr. Bose, second by
Trent.
Trent by Mr. Petty. All in favor, please say aye.
Aye.
All opposed? Motion passes unanimously. Okay, item 5D, please.
This next contract is with Roche Diagnostics. It is where we did an RFP this year for reagents, which are utilized in our lab for HIV testing. We estimate the annual cost of this is about $425,000 a year. It's a 3-year initial term contract with 2 one-year extensions. So over the 5-year possible contract term, this could be about a $2.1 million expenditure. It is budgeted.
Okay. Any questions for Ms. Clark on this item? Okay, entertain a motion for approval. A motion for approval by Dr. Ziegler, and do I hear a second?
Second by Dorothy.
Second by Mr. Bose. All in favor, please say aye.
Aye.
Opposed? Motion passes unanimously. Council, any report?
I have, Mr. Chairman, is for the month of May, there were 37 contracts that were negotiated that were below the $500,000 threshold.
Okay. And to my knowledge, we have nothing in closed session.
I don't have anything. No.
Okay. But with no other further actions, we are adjourned. We'll
Okay.
reconvene at 11:30 for governance.
Okay.
Good afternoon. It is 11:30 on, I don't even know what day, June 25th, and I'll call the governance meeting to order. Thank you all for being here and tuning in online. And we have a mixed bag. We've got some from home, we've got some from offices, and we've got some here on the third floor at the hospital district. I'm informed that there are no citizens wishing to address the committee. I'll move for approval of the minutes from February 27th.
Move approval.
Ms. DeBose moves approval. A second?
Second by Amanda.
A second from Amanda. Well, I guess we'll do this. We'll vote negatively because it seems to work better on this platform. Is there anyone opposed to the minutes of February 27th? Hearing none, the motion passes. I don't have much of a committee chair report other than to say welcome back. This is unprecedented times for everybody. And I guess as the kind of the shock and awe of the pandemic has sets in and we get to whatever the new normal is, I'm happy to see that our committees are beginning to get back to work and the business of the hospital district is continuing. I have to give a big shout out to the doctors, nurses, housekeeping staff, people in the kitchen, everybody at this hospital district from all the various campuses that have made this happen, made this work. There are heroes here, and it's anybody, in my opinion, that receives a check from JPS, because it takes each and every person to do it. We are here. Those that are in person have masks. We are way more than 6 feet apart. I do encourage everyone to wear your mask when you're out in public. It's certainly not a fashion statement, but it says more about you taking care of your fellow man. So that's all I have. We will move forward with the agenda, and we'll go to item 5, which is an ERM update from Mr. Skillins.
All right, thank you. Jeffrey, we'll go ahead and put up the slides. Well, while we're pulling the slides up, what I'll say is the compliance, internal audit, risk functions have been also in a period of shift as we have gone through this period of time. But that doesn't mean that we haven't been busy. And so you'll see in the agenda that we have for you today that there are several things that kind of have built up since we've last met. And so let's see if we can get this to go. So Jeffrey, might probably have to have you advance the slide for me. All right, next slide. And one more. Okay, so as you all know, it's been a while since we've met, but we, as a reminder, have 12 enterprise risk management risks that have been identified over the last 3 years. And each of these risks have an executive owner associated with them. And what we do, just as a reminder, is we go, once these risks are identified, we take a deeper dive with the executive and their teams to identify the specific risks in the area, as well as initiatives and risk mitigation strategies that are put in place. And so today we're going to talk about cybersecurity. One of the reasons why this is on the agenda today, among many other reasons, is given the COVID pandemic, cybersecurity has always been a high risk, but particularly in this period of time, it has taken the forefront as it relates to its risk profile. And so I asked David if he could give a brief update on cybersecurity.
Thanks, Ron. Thank you, Governance Committee. I am on site, but I'm in an undisclosed location right now. One of my roles during these virtual meetings is to make sure we don't hear dogs barking, and watching the mute buttons and all of the papers that go in front of cameras, trying to do that as best as we can. So I'm off in another room so that we can do the production in that room. So anyway, I want to give you a little bit, because it's been about a year since I came before this governance committee to give some cybersecurity information and where we're at from an organizational standpoint, And Ron and I have partnered together over the last couple of years, and with Michelle and now with Tim, looking at the cybersecurity risk. And where we were a year ago is not where we're at today. We've made a lot of progress. And a lot of that is due to the hiring of a chief information security officer that we have now at JPS. And Mike Russo joined right at 13 months ago and has put together a cyber program that has really mitigated many of the risks that we were seeing, but also understand that cyber is not a sprint. Cyber is a marathon, and it's a daily grind of things that we have to do, and a daily grind of things that our organization and our patients, as well as our employees, have to do. So when we put this together, we did some definitions around cyber. And we changed the key risks this year because our workforce has changed. And when we, back in March, sent the majority of our office workers home, we had to re-stratify our risks to the organization. Because now that we have over 1,500 people that are working at home on a daily basis, and those 1,500 people are on their home networks. They're not on JPS network anymore, but they're doing work on behalf of JPS every day. And as I've told many of you before, prior to March, we were in a situation where the data of JPS was in the four walls of JPS, and it made sense that it was in the four walls of JPS. Four walls being virtually, of course, throughout all of our community health centers and data centers and all of our locations, but it was confined, and we only had to share data when we had to share data. Now that we have 1,500 really remote locations, we weren't set up for that, and we had to quickly move that direction. So we saw some increased cyber attacks happening on home networks with people that we weren't expecting to happen as quickly as we moved out. We saw some additional ransomware attacks that were happening just on local PCs. We know that we have some unsecured medical devices that are out there that we're working with right now. We know that social engineering is an issue. That was a big issue a year ago in 2019 when I first came to the governance committee, and it's still an issue today. I think that honestly, the way the world has changed in the last 90 days, this issue may actually start dropping off. Allowing anybody and everybody throughout a hospital district, because we're so nice and we have visitors and we have patients everywhere. The social engineering standpoint, I think, has actually came almost to a halt. Because now, if there's an unmasked person or a person that a nurse does not recognize on a floor, they are questioning that daily now. And so I think our awareness around that is going to decrease this risk over time. Data mining of JPS credentials, basically that means is when someone puts out on a website what their credentials are, that can then be food for hackers to be able to take that credential and move it back. We were having a risk with limited security risk analysis, but that has been mitigated now. And I'll talk about those mitigations here in just a minute. Mobile device security has been mitigated as well. And third-party risk, I think we've done some mitigation as well. So before I get into the mitigations, does anybody have any questions about the risks that we have identified coming into this FY20 year?
No.
Okay, great. So here are some things that we've done. Some of it was planned to be done. Others of these were not planned at the beginning of FY20, but we have adapted to certain regulations that have been applied to us and certain regulations that have come to us just as part of COVID. One of those things was cybersecurity training. And you heard Robert Early speak of this at a board meeting just a couple of board meetings ago during his CEO comments, that we were going to be going through a cybersecurity training for the entire organization. And I'm pleased to announce that right now we have over 4,500 people that have taken this cybersecurity training, and that has been since the second week of March. So in the last 14 days, we have went from 0 to 4,500 people that have taken the cybersecurity training, and we're very happy about that. And that was a requirement that came out of Texas House Bill 3834 that said we needed to train the entire workforce on cyber. What we concentrated on with the cybersecurity training this year was work at home. That we had a lot of options that we could have went down, but because of the current state that we are in, we decided to go to a work from home cyber training. And because there's lots of overlap, working at home, working within an office building, but that really resonated with a lot of our employees. And so we did that, and I'm very happy with 4,500 people have already done that training. We've also increased our cyber liability insurance that Ron has brought
David,
to.
may I interrupt you and just ask a question?
Yeah, go ahead, Dr. Weber.
Should board members undergo the cybersecurity training?
They did not. But here, and we chose not. What's that?
Should we undergo it?
So there's a couple of things. The answer is yes. And I will be happy to send you the link to the company that did the cybersecurity training for all of our employees. Okay. It's an external link, and I will send it to y'all. It's a CBL. It's a video that you can watch. It's very high level. It's not meant to be a crash course. It's actually only about 5 minutes to go through just reminders of things that you need to watch for. I think it's good for everybody to go through these types of refreshers. We did not include the board from the very beginning because the House Bill 3834 did not require that, but I think it would be very good for you all to go through that.
Okay, thank you.
Great. Great question. One of the other things that we've done is we've employed multi-factor authentication. Now, let me kind of talk through that just a minute. When we talk about multi-factor, we talk about several things. Everybody has a password to something. That's a single factor authentication. There's two-factor authentication, which is what you know, but then also what you have. And in the old days, maybe 10, 15 years ago, you would see people carry around these credit card type things that would randomize numbers. And maybe every once in a while you'd see this randomized number typed into something. That's a token factor of authentication. So you would see financial services companies, a person log into like the Federal Reserve, and they would first put in their password, and then they would put in this randomized digits that were on their credit card. We've advanced past that. Now we use smartphones to be able to get those randomized digits. So we employed multi-factor authentication to our physicians about 7 years ago. We went live right after we went live with Epic. So if a physician was writing an e-prescription for a narcotic, they would get a code on their phone that they would have to type in to release that prescription. That's two-factor authentication. We've now done that same two-factor authentication for remote workers, so that in case somebody were to lose their laptop, that maybe a password was cached and saved on that laptop. If they were to lose their laptop, or one of their kids got a hold of their laptops, or they left it at Starbucks. Well, actually, that's not a good example because Starbucks are closed. But they were at a park, parks are closed. That's not a good example either. Let's just say they left it in their car. Sorry, it's a different world right now. But if they left it somewhere and someone else got a hold of it, then just because their password's on that machine, they still can't log into JPS. And so we now, when they try to log into JPS, they have to put in a code that's texted to them. So they have to have their phone, they have to have their laptop, and they have to have the credential to get into their phone to get to that text message. Then they can remotely access JPS assets. We're doing that across the board. We've been working on that for about 6 months. COVID forced us to really push up that timeline as well as some other timelines. So that has mitigated a lot of the risks that we have here at JPS as well. We're also now doing Department of Homeland Security vulnerability scanning and testing.
Hang on, David. Steve has a question.
Quick question, David, on the authentication where you get the text, is that for all kinds of entries, or is it just for specific kinds of work flows?
So
because that seems like it'd be really cumbersome.
It's really not as cumbersome once you do it the first time, right? When you do it the first time, it is cumbersome, but then you get used to it. So everybody that comes in on a virtual private network has to go through multi-factor authentication, right? And again, people are used to it. When you change your password at Citibank or at Chase or Wells Fargo, they text you now, right? Just to make sure that's you, they text you a code. It's the same thing that we do here now when you log in. Now, when you log in, you're on for 12 hours. And actually, we won't even log you out for up to 18 hours. So you can stay. So we're actually promoting an 18-hour workday pretty much from that perspective. We're actually seeing that productivity actually go up, and that's a whole nother conversation. But we really needed to put that in place so that when people were logging out at home, and they were getting off the network, someone didn't just pick up their machine and do something else with that machine, and that puts another layer of security on it. So, great question. We are now using the HHS.
Hey, David.
Yeah, go ahead, Amanda.
Sorry, I just had one more question about that. How many employees are we looking at that are utilizing these different types of VPNs?
Yeah, so the VPN right now is at 4,000, right? Now, that's not how many people are using it, but we had to give access to our physicians that may be doing telehealth, or maybe just, they're a weekend warrior and they're only working here on the weekends, but they're not here, during the weeks because they have other things that they're doing. So we had to open it up not just for employees, but also to all the physicians that would be doing remote access. And we have a lot of physicians that do remote access, right? Because it's all hours of the night that they get called, and it's all times of the day. And if they're covering for different services, they have to have that access into JPS, into Epic, to be able to cover those patients. So it's employees and physicians that are on that right now. Great question. So vulnerability scanning and testing, we've been doing that for many years. We do it once to twice a year. We pay outside companies to be able to do that. We decided to step it up this year, and the Department of Homeland Security has a free service that will do vulnerability scanning as often as we want to. So we have now employed that every 30 days. We are now scanning ourselves and getting a report from the Department of Homeland Security to make sure, one, there aren't new threats on our network that we didn't understand, but then number two, making sure we close the gap from the previous month. And that's just kind of a tell of the times, right? Our cyber threat changes pretty much weekly, and we've got to be able to close those gaps as quickly as possible. So we're doing these scans as often as we can.
David, are there any safe harbors for using the Homeland Security scan?
No, that's a great question. The Homeland Security scan out is just a free tool. And again, it's a lot of these things, safe harbor kind of gets thrown out anyway, right? But these are defensible actions that we can say, we did this as a best practice. And we can show the logs, we can show the reports, we can show the corrective action plans, we can show everything that we did as part of doing these scans. So if we ever did get penetrated, or we ever did get ransomware on our devices, or we ever did have a breach of HIPAA data, HIPAA PHI, protected health information, or HIPAA protected data, we can go back and say we did these 17 things on a weekly, monthly, annual basis to protect us. And usually at that point, if we can show that due diligence, a lot of these things get thrown out. Okay.
Very good. Thank you.
Email endpoint security, again, working in a new world where people are working in this hybrid world. What we found was people were emailing themselves their Yahoo or Gmail account work that they needed to do at home, right? So again, think about it before we all went home. 6 months ago, when people needed to do some work at home, they may have just tried to put a spreadsheet or a list of patients on a SharePoint site, or on a box.com or a Dropbox.com site. Or if we blocked all of those, then they would just email it out. They would email this document with all of these things in it, and then they would work on that document at home, and then they would send it back the next day. And that's really not an approved way to do things. And so we went out and put some processes in place, put some technology in place, so that was no longer practical for them to be able to do. Because we lose control of those types of technology assets, information assets, when someone puts it on their own Dropbox.com SharePoint or shared site, or if they try to email it to them. So we have stopped that practice. And we actually get reports now going to the compliance department and their privacy officer there that watch over that on a daily basis.
So we can actually see if someone emails a spreadsheet from their work email address to any other email address.
Yeah, in fact, we not only see it, but we have an automated process in place to do the monitoring, and our privacy person that's in compliance then will go through and look at that to see if it was a false positive. Maybe it was a legitimate file they should have sent and could have sent, But if it's not a false positive, then we actually have a corrective action process with that person and potentially with that person's leader to re-educate them on why that is not an appropriate practice.
Yeah. This is DT. Do we have encryption type thing like from Zix and stuff like that?
We actually use Proofpoint, right? So Proofpoint is our engine that will encrypt emails and stop that email from the very beginning. So we have HIPAA, financial data. We have all of these filters that are prepackaged into Proofpoint, just like Zixmail, right? They work exactly the same. And on the back side of things, those encryption protocols or those encryption systems, if we have one and let's say we're sending a patient file to Aetna or to Cigna, right? And one of our patient account representatives needs to send that file. Since they're using the same encryption protocol that we do, we will automatically encrypt that email in flight as it's leaving our premise and goes to an appropriate premise on the other side.
Do we have capability to word searching to pick up stuff like confidential date of birth, social security that are automatically encrypted?
Not only do we have the ability to do something if there's like the words SSN or the letters SSN in a file, right? We actually look at the content of every email if there's 9 numbers that are sequential, right? Or 9 numbers that are packed together. Maybe they didn't use the nomenclature SSN before those 9 numbers, but we do an assumption if there are 9 numbers with associated dashes or without associated dashes that tries to leave our premise, we assume that's a social security number and we block that email.
Including attachment or without
included in attachment. So even if it's in the body of the email, it's blocked. If it's in a Word document or if it's in an Excel document, it gets blocked as well.
Okay. Do you guys have some sort of like SOAR, SOAR? I think you're familiar with that word.
That word is not resonating right off the top of my head.
It's more for security, orchestration, automation, and response. So it's more for threat, vulnerability management, security incident, I think.
Right.
It's probably be called something else, but it's within that line time frame.
Yeah. So there's some new nomenclatures that have came out. SOAR is one of them now that you identified that. The SEAM is the one we've been using within the organization, industry for probably about 15 years now. And that's a security incident and event management tools. So we do have a team that is running within our boundaries. And we take all the logs from firewalls, from all the logs from switches, all the logs from our access points and our Active Directory systems, and we put it in that SEAM, and then that comes out and shows us the events. There's a correlation engine built into that SEAM that tells us the ones that are false positives versus the ones that are really ones that we need to investigate.
Okay. And is that a different service than the regular cybersecurity that you guys using?
So there are 2 pieces to it. It is a service, but it's one that we have on site. So we don't have an outside services company that's watching over these. We are doing it ourselves. Now, what I will tell you is part of our FY21 initiatives that we are putting forward is to move that outside of our walls. And that is something that we are looking at the cost of doing that. That is not an inexpensive thing, but the attacks are happening so rapidly right now that for us to pretend that we could keep up with them, it's a losing proposition. So that is part of our initiative next year to attempt to move that outside and let some of the companies like the AT&T Cyber Connect there are several companies that do that that will do that as a service for us.
Let me ask you this because we can move into an executive session later on, or we can have it offline because I know we are video streaming, so there's a lot of sensitivity around cybersecurity and all that stuff. Do we have the capability to detect because the way that people can do to clone a database, clone our other stuff off the dark web? Do we have the capability to detect that?
So we are not watching that with automated tools. right? However, we do have some services that are watching it for us. And we get reports when like a JPS health email email address shows up on the dark web, right? Get those reports. When it looks like something that was emailed out on behalf of JPS and it ends up on the dark web, we get that report, right? So it's not something that we are spidering out on a daily basis, or on a real time basis, but it is something that daily we get a report of anything that's out on the dark web that may have something that has to do with JPS.
Okay. Yeah, we can take it offline because I this is sensitive issue because I've seen stuff but on JPS network that's being cloned. That's why I asked.
Yeah, I would encourage that to happen, maybe face to face.
Yeah, absolutely, absolutely. Yeah, we can absolutely do that. Let me also tell you that one of the things that we also did this last year was we brought in Beasley to help us, which is our one of our cyber partners within cyber insurance, to help us do a cybersecurity tabletop exercise. And that was very, very thought-provoking. It was some of our executives that got together in a room with them, and they orchestrated a day 1 through a day 21 events around a table of a ransomware attack. Now, that was really, really powerful because it opened up the eyes to a lot of our leaders within JPS that this is not an IT issue, right? When something like this happens, the IT perspective is just to get things back up and running. But the operational perspective and the emergency management perspective then has to kick in to understand that we still have daily operations that has to be done. We still have to get paychecks out the door. We still have to get monies from insurance companies. We still have to get our patients seen and taken care of. And that was very thought-provoking. And we're going to be doing that on an annual basis now to get people around the table, just much like we would do, a disaster recovery exercise or an emergency management exercise. We need people to be thinking about cyber and what the effect it can have on everything. And lastly, one of our mitigation strategies has been an upward investment in technology. That's not going to change. We're going to continue investment in security protocols as we move forward. So that's the end of my prepared remark. Does anybody else have any other questions for me?
David, let me ask a question in regards to members of the board of managers and email addresses. I know that most of our emails are, if not all, are our personal emails. Is that a policy that should be changed to where the board of managers are using an email address that's within the system?
Here's my personal belief, and I'm going to work with Ron to come up with that policy, right? Number one, a lot of the things that we do within the board is open records, right? So the closed sessions obviously are not. So I do believe we need to bring you guys in so that we have JPS Health email addresses that you guys can have access to, right? That formalizes the approach. And if we are ever in a situation where someone got a hold of something confidential that they should not have had, then we can look at it from an internal perspective and say, here's what we did to mitigate that risk. All JPS board members were on JPS Health email addresses, and here's how they received that message. And we can that's a defensible action at that point, right? Because if you guys go and on your personal email addresses, again, as I spoke earlier, we lose control of that. And then you can forward it on to other people, or if someone else has your smartphone, they can forward it on to other people. And I just don't think that's a practice we should do. Before I came, I know about 10 years ago, we did hand out JPS Health email addresses to the board members. I think it's time to refresh that. I know DT has asked about that in the past. So I think we need to refresh that. And if you guys are amenable to that, Ron and I will work up what that action could look like.
Well, I think it's important in every action we do, we practice what we preach, so to speak. And obviously, cybersecurity represents a big risk for us. It seems strange that the people who, quote unquote, manage the hospital aren't following the same protocols as the people who touch the sensitive data every day. I would be in favor of that and bringing forth a policy that the board can look at. I realize that it might make it a little more inconvenient maybe be a little bit more difficult to get email. It might make your phone ring a little more when someone can't remember their password or whatever else. But I think if we're all within the confines of the system, then overall we're going to be better served for it.
Yep. Okay. Agreed. We will. I'll work with Ron and we'll put that together for this team. You got
Any other questions?
I have a question around telehealth.
Mhm.
With the COVID-19, there's waiver from CMS or Department of Health and Human Services.
Yes.
So it's more like a wild west. When should we start looking at reining them in?
Well, we already have, right? So we already have here at JPS, right? So there are only, so let me level set for the group so that we can understand what happened. On March, in the middle of March, when COVID really started breaking out across the country, and we started opening up services, CMS was and HHS were very at the forefront, saying if you need telehealth, let's open up all of these applications, right? And these were applications that they had previously said no to. So like FaceTime groups was now an appropriate way to do telehealth with a physician. Actually, I'm sorry, Google Groups was now appropriate. FaceTime was now appropriate. And all of these technologies that are consumer grade were now appropriate to do telehealth, right? At JPS, we had a little bit of that wild west that happened. The leadership at JPS underneath Dr. Hochberg and Robert and Dr. Duncan, we reeled that in very quickly. And probably it was just a couple of weeks, actually. We had that reeled back in, and we had deployed 2 new services for telehealth so that everybody was using the same service. That first service was the Amwell application that we had already rolled out to employees. And then we were using that now for urgent care on demand through our website and through MyChart. The second one was through Secure Video, a partnership that we have with Secure Video that uses the Zoom platform. And we were able to roll that out for all of our students that we were doing telehealth. So we have now we don't have anything going across Facebook or going through Google or FaceTime or anything else like that. It's only on those 2 platforms. I'm sorry, go ahead.
For the Zoom platform, is that the subscription model or is that the free model?
So it is the subscription model. And we now have 2 contracts in place, not just with Secure Video and Amwell, but we have 2 new contracts in place, one with Zoom directly for their PHI HIPAA protected licenses. We also have a contract with a company called Video. It's spelled Video, but it's pronounced Video, VIDYO. We have a HIPAA secure contract with them as well. What we're going to be doing with that contract with Video is integrating that on the back end of Epic. And we're going to be going live on that on July 22nd. So that when a physician wants to be able to do a telehealth visit over video, they click a button within Epic and Video then comes up. It then makes the connection with that patient and it's encrypted from end to end. We have that business associates agreement and those HIPAA licenses from Video. So we can do things through Zoom that is like peer reviews for physicians to be able to talk. And we also now have a contract with Video that we can do that. And all of these other platforms will come down when we go live with Video.
Okay. Is that something that also incorporate? I'm not sure for our care management team I'm not sure how far you guys are with the CCM, the chronic condition management. Is that incorporate all seamless on the telehealth side also as well, or it's different platform type thing?
Yeah, that's another question we're going to have to come back to UDT and answer on that. But we do have, as Sharon kind of mentioned in Finance Committee, we have a lot of people that are doing telehealth right now, right? Our case management team, our case managers are making those phone calls and making those video calls throughout the process as well, right? So as we get better with the integration of care management within Epic, and we get this video platform up, that will be a strategic look forward so that we can do those things as well.
Anybody else?
Is that going to cause some challenge for you? Because all of those video conferencing have the capability of recorded, and then the storage of those and all sort of things that comes into play.
So the video contract that we have does not allow for recording, right? We purposely did that so that a patient could not record the visit. And really, it's kind of a not a best practice for a physician to record the visit, right? It's from a legal perspective, it's not a best practice to record that visit, right? So we've taken that out of that capability. And now Zoom is something different, and that we're not going down the Zoom direction yet for these telehealth visits. We may in the future switch over to Zoom, and we'll look at that capability as well. But all of this stuff is in the cloud, and that's why I think we have to be diligent to make sure that if we start allowing recording of visits, that we have the appropriate safeguards from that company, that those visits cannot be seen from anybody other than us.
Do we have a 10-year contract with you or a franchise type contract with you yet?
I didn't hear that question, DT. Try again.
Do we have a 10-year employment agreement with you or a 10-year franchise type contract?
You know what, DT, that is the best offer I've had all day, and I'll take that.
I think it depends on the murder hornets.
Exactly. No, I'll take that as a compliment. I appreciate that. Thanks, DT.
Does anybody else have any questions for David? I can't see everybody, so speak up if you do. All right. David, thank you wherever you are.
Yeah, thank you, David. And as David indicated, we have a close partnership with IT. Cybersecurity and compliance are very closely connected. And as he indicated, our privacy officer, Sarah, works with their security folks and regularly does data loss prevention emails to where if there's any patient sensitive data that leaves JPS to monitor that. And we're going to actually talk about that in a subsequent slide. So thank you, David. Well, before I move, Mr. Chair, I will go to the next agenda item, which is policies for approval.
Sure.
So there are three items on the agenda for today in policies. The first is LD 6000, historically underutilized businesses. This is the policy that we've had, longstanding policy that we've had for historically underutilized businesses. The reason why this is coming before the board is it has reached its 3-year time limit for reapproval. There has been some minor changes to the policy. It is in the packet with the changes that were made and also legal reviewed. We do have Michelle Green-Ford here if there are any questions related to it, but for the most part, there's non-substantive changes.
Mr. Chairman, can you hear me?
I got you.
This is Reverend Emerson.
Yes, sir.
I have some questions, and I'm asking that we pull this and take it back and through further review. There are some other areas on this policy I think that we need to address. The diversity policy was developed over 11, 12 years ago. And there are some things in it I think that we need to address more than what we have redlined in this policy. So I'm asking that we could pull this from the agenda and we can get with Michelle and staff and look at some of the things that's in there.
Are there specific items that you would like to address, or would you like to send those requests to Michelle? How would you like to handle that?
Well, there are some specific things, but it's kind of an array of items. One, I'll give you an example. I'd like to address the 25% that we have in the policy now. That's over, like I said, over 12 years old. Also, I'd like for us to address those excluded businesses who don't have to address the 25%. I'd like to discuss that particular area that's in the policy also, and then there's some other things.
Uh, Roger,
Yes.
can you hear me?
I
I
got you.
also had some questions with that. And one of mine was in the exclusions, and that was other operating expenses. We've listed everything but the kitchen sink, so I couldn't figure out what that was. So I think maybe going back, just doing some more due diligence to this would answer some of those questions. But one of the questions that I also wanted to ask is under your certifications, all business, small business, is there a reason why everyone have to have certification, but it's not required for the veteran-owned small business? That's some of the questions I had.
Okay. I don't have any problem with pulling it and tabling it to a future meeting. What I want to do is figure out a process in which we can get everybody's concerns addressed appropriately and properly before bringing it back.
Right.
Right.
So I guess the best way we can handle this is for those who have questions or specific issues with any of the wording or changes to the policy, if you could email myself and Michelle Green Ford, and then we can, what we may end up doing is putting together a small group to kind of go through all those requests and then bring it back at a future meeting.
Roger, yeah, I would agree with that. That's what really was one of my concerns. I was hoping that a committee could be formed to actually discuss the policy in its entirety and look at some of the things that we are requiring, some things we don't require, some items that don't go by the diversity review. So I think it's an array of things. I think we just need to seriously look at the policy as it stands now. So I would hope a committee could be formed to do that review.
That sounds like a fair assessment, and I know that I'm speaking for Michelle. She would love to help us with that. I will talk with the executive committee, and we will put a small group together to move this forward.
Sure. Right.
Okay. So let's go ahead. If I can have a motion to table this item to a future meeting. Moved by Reverend Emerson. Seconded by, I got Dorothy. Anybody opposed tabling this?
Well, you got an opposed, the dog.
Yep.
Oh, the dog opposes, has no vote standing in this meeting. So we will
Ex officio member.
Yeah, we will table this to a future meeting, and then I'll work with the executive committee to see what we want to do about establishing a small working group to get these concerns addressed.
Great. I know, Michelle, did you want to say any final remarks before we move on?
Yes, I actually did. I just wanted to make sure I wasn't still on mute. Can you hear me okay?
Yes.
Wonderful. Yes, I just want to thank the board where I have an opportunity for all of the support that we receive for the diversity and inclusion initiatives. And the items that were mentioned are all things that we have answers for those, and we have dialogue that we can definitely engage in. So I feel really comfortable, and I have all those noted. So I look forward to the group that's going to come together so we can go in further detail. But I just want to thank the board personally and this committee, Roger and Ron, and all that you've done to help. Thank you.
Thanks, Michelle.
The next policy is PRV 200, Employee Access of Personal Medical Records Policy. As you recall, this policy was at the last governance meeting. There was some debate about it in terms of whether physicians and caregivers that are treating employees as a normal course of care delivery were implicated by this policy. And so it went back for revision with Dr. Hurd, Dr. Haynes, and others, as well as General Counsel's office. And what we did on this summary slide that's shown here is highlighted in red the portion of the language that was added. It's also in your red line version as well, that indicates that that personal medical records by JPS employees, officers, directors, contractors who are involved in the treatment or care for patients or operational or financial purposes related to such involvement are permitted to do so. I know there was the policy in the prior version was a bit silent on that, and I wanted to make it more explicit. So it's coming back to the committee for consideration for approval.
Thanks, Ron. Dr. Ziegler, I guess you can speak for Dr. Haynes that he had the biggest objection. I assume that this is good, and I know that our attorney set to work that out, so I assume that we're all good there as well.
So this is consistent with what I understand Dr. Haynes raised this. Yes.
All right. With that being said, I'll ask for a motion to approve.
So moved, Roger.
Is that Mr. Chairman? Was that you, Dr. Weber?
Yes, so move
Okay.
approval.
Got a motion to approve by Dr. Weber. A second?
Second.
Second by Reverend Emerson. Anyone oppose? Hearing none, PRV 200 passes. The next item up, I believe, is the standard operating procedures that were tabled from the February 27th meeting. I know that Ms. Dorothy and Amanda and I met at length along with General Counsel to up those standard operating procedures, which haven't been, I believe, updated since 2006. There was some concern that we didn't have enough time to read them at the last meeting. I made sure that staff resent those prior to this meeting. And if there's any discussion or changes that need to happen, let's talk about them. If there's not, I'll look for a motion to approve.
Roger, I have some changes that I'd like to talk about someday.
Sure, let's talk about them.
I got to make sure the dog's not eating the chair.
It's his prerogative to eat that chair.
All right. Am I on?
You're on.
Okay. Under A1, since we're moving to in-house counsel, we will no longer have a general counsel's office, is my understanding. And that, I guess that just should be legal.
Sure, and for the sake of this discussion, I would prefer, because there's going to be a whole slew of policies changes that will happen once that whole process is initiated and enforced, that those small changes such as that are changed at that time. That way we're in compliant with policy today.
Okay. Do I need to denote the changes or the Roman numeral and the number? I mean the A, etc.
Yeah, that would be helpful, or and page number if you have it, just for quick reference.
And then this will be what when we finally finish the process on legal counsel, then these will come back for review.
Sure. Yeah, I would imagine there will be many documents that we look at that will come through that will change general counsel to legal counsel or whatever terminology.
Well, just one for sure, and that's the footnote number 1 on the right up under developing the board meeting agendas. The Board of Managers Executive Committee has only been the chair, vice chair, and the secretary. We have not included the immediate past chair of the board.
I guess related with is there a reason why we want to add that from the committee that worked on it, or we want to add that fourth person?
I think more or less continuity more than anything. Certainly the chairperson of this board interacts with staff and administration probably more than a day-to-day board member does. And at least having that extra person in the room is certainly on difficult topics is beneficial. I don't know that it's a mandatory that immediate past chair shows up, but it's not unusual in board situations for the immediate past chair to be included on that part.
Where are y'all in this policy?
Page 2, the footnote at the very bottom.
Okay. All right, I'm thinking, what did I miss? All right, okay.
It was more or less good governance and continuity.
Okay.
So I believe in the bylaws, we just have to look, I have to look at the bylaws to see what consists of the executive committee, you know.
I don't have the bylaws in front of me.
Steve, this came out of the bylaws, which have not been amended, and that still reflects those 4 being part of it.
4.
Yeah.
And I really had no objection to it. I guess my concern, and Dr. Weber, I don't mean to be stepping on you. I think you're in the middle of your questions.
No, you go right ahead.
Yeah, I don't have really an objection. I hear myself. I'm gonna take those off. So, can y'all still hear me?
Yes.
Sorry,
Yeah.
I hear my echo.
Okay.
Is if we do add that 4th person, that's 4 people, but now we're also empowering that executive committee with the ability to approve or not approve instead of just the chairman doing it. So now we have 4 votes. What happens if we get a tie?
Voting member.
There you go. Okay. That's a good answer.
I couldn't understand you, Roger. What?
You could have the immediate past chair as a non-voting member of the executive committee.
That way you still have a way to divide the vote if necessary. So really my question goes back to the on item 1, A1. And I think we just need to tweak the language. We're going to recommend that we consider tweaking the language. As I read it, it looks like and I'm sorry, I don't have my glasses, so I can't read exactly what it says, but we're putting 2 people in approval, the approval loop, the general counsel and the communications person. It says, and for approval of the agenda. What if they don't approve?
That's actually what process has been ongoing forever that I know of. And
well, can we clarify?
It's not a matter of approval, probably. It's more of a matter if from my perspective, I'm looking to see if the language is legal. And from that perspective, mine's not an approval of the item being there or not.
Right.
And then the communications is looking at it from a public standpoint in terms.
No, and I'm all for that.
Okay.
I think as it reads, though, it says for approval. So, I would say let's.
We could just take out final approval. Just forward to general counsel
for review, because obviously I want both those people looking at it for those reasons.
Fine. Yeah.
Let's take them out of the approval loop.
Take the phrase and the final approval.
Mm-hmm.
Okay.
Yeah. Okay.
Yeah. For review. Yeah. And that's consistent with what happened.
Yeah. And down below, and again, I'm sorry, I can't read the paragraph at the very bottom of that page. Yeah, maybe that might work. We changed something that I think 14 days from 14 business days. Calendar days.
I don't know what that is.
These were changes that clarified items to the Texas Open Meetings Act and the posting requirements and the logistic amount of time that it actually takes.
Staff. Yeah.
Because that's a long time. That's 2 weeks. I mean, I just want us to consider that. That's a long, because a lot of times people don't think of it until like the week before. And so, I mean, it's putting a lot of pressure on being able to add things to the agenda.
But we don't even, Steve, I'm with Steve on that one. We don't do the agenda 14 days ahead.
If I could speak, nope, I can't.
We can
All
actually
right,
hear you.
can you hear me?
Yeah.
So for Finance Committee, if you think about posting, and I'm just going to play today's date, We have to post the agenda on the 19th for a meeting on the 25th with the county. And to get the agenda and the packet ready, we actually start with a deadline for internal staff. You've got to have me your agenda item on the 16th. So we may be able to shorten that 14-day, but in order for us, there's a lot of work pre-posting the agenda. So the 14 days may be a fair time frame.
And in review, I sat down with Allison and we talked about this for a long time, and we found what is realistic and what we've been doing based on calendar. Just because of the many steps of review, the volumes of information that goes into it, we felt that 14 days was a fair estimation.
Yeah, 14 days from the date of the meeting.
Date of the meeting.
Is about right.
Right.
Yeah.
Now, that doesn't mean to say if emergency items pop up, whatever else, we still have that 72-hour window.
Right. Yeah.
Got it.
But if it's a general business item, it needs 14 days to make it through the various steps.
Okay. If that works for staff, I mean, how does the rest of the, well, that's not my place to ask that question.
Well, there is another under item 6. It says no item may be placed on the agenda less than 72 hours in advance of the meeting unless an emergency or urgent public necessity. So I believe that even with the 14-day posting, that there still is availability to put items on the agenda after it's posted. That's an updated. I think we follow that quite frequently as well.
Okay, good.
I'll just note there were a slew of changes from the Texas Open Meetings Act that are reflected. A lot of the blood that's on this document are requirements from changes in state statute.
Got it.
And Steve, also, it was a matter of incorporating what we were practically already doing.
Oh yeah, no, I get it.
Okay.
No, I appreciate that. Just for the sake of maybe trying to make it better, on page 3, item B, notification of meeting. Item B2, board members will have access to information about the agenda and agenda items via secure web portal. Do we want to put board members shall be notified of a meeting? So that the access to that information piece of it, do we want to put a time limit on that? I mean, that's something I've stressed to Robert before. Sometimes we get a 600-page agenda, and I'd like to have a weekend at least.
Well, and that goes into the 14-day review period.
Right.
And Steve, practically, that's what we try to do is we post the meeting on Friday, and Sharon's office and my office works back, trying to meet that deadline so that you do have access to that over.
Right. Do we want to codify that though? Do we want to say, give us, 72 hours? Something that says, we have to get this board book before access to the information.
You've got item A.
I know in practice we are, but
item A says 72 hours prior to the regular special meeting.
What says notify?
Yeah, notified.
Say access to the information.
We can say notified.
I'm with Steve on that because I go and read my stuff when I get it, but then sometimes on board days, some additional stuff has been added. So I think that we should have that the information would be there.
Well,
go ahead. Consistent with what we're doing, we can add that 72-hour requirement to item 2 as well. That's what you're suggesting.
They're not strong enough.
Okay. Well, we just add 72 hours to the B2.
Yeah, that'd be perfect.
Okay.
Let's see, and truly, most of this is great stuff. I applaud it and support it, especially the travel stuff and the education stuff. Is all good.
Now that we can't travel, we got to fit in just in time.
And this is old language. It has just but let's go ahead and polish it up if it makes sense to everybody. On page 9, there's we've moved stuff regarding the secretary. Item H.
On page 9. or
Page 9. Well, 9 of what I had. I think I had the week February.
What, 9 of what Steve has without glasses. So page 7.2.
Item 8H.
Wait a minute, 8.
Right, on page 9.
If you're looking at the paper copy, it would be page 8,
Oh, okay.
item 8, and section H, the secretary shall.
Yep. Ensure, that's the wrong use of the word ensure. It's supposed to be EN instead of IN. And it says, and again, this is old language. This isn't new. This is just moved. Ensure that accurate records are kept of what and how. Do we want to, is there any clarification? This is sort of an open,
Yeah, right now that's Suzanne.
Yeah.
And so, and that's consistently who it's always been. She's sort of been the keeper of all the board's minutes.
But that's really Roger, right? That's board.
It's Roger, but Roger.
But Roger makes sure
I'm signing whatever Suzanne.
Roger does whatever Suzanne tells you to do, like I do and everybody else.
Yeah. Are you really challenging Suzanne here, Steve? Is that what we're?
And then item 2 there,
Where are you?
On H2.
Oh, yeah.
Again, that's old stuff.
Yeah. We brought over, didn't catch it. Sorry about that.
It's not your fault. Whoever wrote it in 06.
No, it is my fault because I brought it over. I should have caught it. Go ahead.
Item 9B.
Okay. Orientation.
This is talking about pickiness, and this is just throwing it out there for y'all to chew on. Item B, the last word is etc. Usually don't find etc. in rules and bylaws and policy.
All right. I accept that.
And that's all I had.
And that's all you can see.
One thing, Steve read.
That's all I can see.
His glasses worked sometime at some point, didn't they?
But if we made those changes, again, we're in, let me back up a bit. I'm sorry.
Where are you?
Back to the very beginning. I like the idea of making, of A1, making the past chair non-voting.
Yeah, down at the bottom of the footnote. Yeah, I got a note of that. Okay.
Obviously have a lot to contribute. But one question I'll put forward, and I don't mean to speak for him. When we looked at this a few years ago when Reverend Emerson was chair. In fact, I pushed for it, was to empower the executive committee. And his concern, and I'll let him speak for himself, but I think it's legitimate, was, the board was prone to insiderism, small groups of people making a lot of decisions. And he had some concerns about, the executive committee being empowered in a way that would do that, would let a few people making a lot of decisions for the entire board. So that's one thing I'll just caution about is let's be careful how we empower that executive committee, that it doesn't alienate the rest of the board for some really critical decisions. So.
Yeah, this is Reverend Emerson. That was really one of my major concerns, was because there were many decisions brought to the board, and not for us to approve, but it was brought to the board because the executive committee had approved it, and we had no say so. One of them was before the executive committee was doing the CEO's evaluation. And then they brought it to the board, and then the board voted on what the executive committee had already gone over. And so that was really my concern. I've always felt the executive committee was the emergency arm when you really couldn't get the board together, or executive committee is where the CEO can pass some things by the executive committee to get a good reading before it gets to the board. That's why my struggle was that I just don't feel we should empower the executive committee with the power to make those decisions that the board are responsible for.
Steve, may I comment, if I may?
Of course. The floor is not mine.
I'm sorry.
Go ahead.
No,
I'm sorry.
I agree with Roger. I mean, with Reverend and the executive, as is outlined in the beginning of this, that's just to set the agenda.
Yeah.
For the board. It's got really no decision-making powers at all. There's no voting on any issues with the executive committee. And then when it comes to emergency things, that's when items are submitted to us from legal counsel. We go over and we approve or disapprove because it is sort of an emergency basis or a contract that's come up for renewal that we weren't aware of, that type of thing. So I'm totally with you, Ralph. I don't want the executive committee making decisions unless it is an emergency type situation.
Right.
Well, sorry, go ahead, Amanda.
Oh, no, I was just going to make mention of the fact that once these are approved, when we do our bylaw review, that a lot of that language would be cleaned up within the bylaws and outlining the powers of the executive committee versus the power of the board, not necessarily in the operating procedures right now.
No, you're absolutely right. And Reverend Emerson, in response, we actually changed the way Robert's or the CEO's evaluation and codified that in this change to move that to the HR committee. So I don't think that we're consolidating power to the executive committee by this document. I think by adding the immediate past chair, we're giving good governance and continuity. And then again, next up for really for everybody on this board is to work on the bylaws, which are also well outdated. And some of those changes, like Amanda mentioned, can be made and clarified in that document because these documents kind of work hand in hand.
Yeah, they do. Let me, if I might comment, Steve, on something you mentioned, and Ralph, as well as what you mentioned. When that issue was raised before, the board made some pretty significant amendments to the bylaws to reflect those concerns in terms of what was the role of the exec committee. That's in the current set of bylaws. That language was taken out back, I don't remember how many years ago, but several years ago.
Okay.
But there's going to probably be some additional changes that Amanda and Dorothy and Roger have talked about in the bylaws.
Okay.
Yeah, Mr. Chair.
Yes, sir.
I have one other question on board response to persons addressing the board.
Yes, sir.
It doesn't, unless I had on Steve's glasses and I didn't see it. But you don't think we should have some statement in there? How do we, we've had so many persons come before the board and we listen to them and then we say, thank you, goodbye. But nobody ever says to that person, a particular person will get back to you to deal with your issue. And I'm trying to see, how do we put some wording in there that says back to that citizen who is addressing the board? It doesn't say anything. It just says, board members, you don't respond. Okay, well, we don't respond, but who responds?
Well, I think that the standard practice has been, and Robert can correct me here, is that when individuals come to speak before the board and have a particular problem, as is mandated by us to be open and out in the government, we allow them to have that opportunity. But Robert or some member of his team responds to that person or petitioner or with whatever particular item. I don't know that in many of those cases it's appropriate that a board member responds, but it's always appropriate for a member of staff to respond. And I think that's what's been happening.
That's been considered.
I don't disagree with that. I mean, I don't disagree with that. My thing is, I think we ought to say something in this policy that concerns will be addressed. That's what I'm saying. I know that he does that, but we don't say that. That's what my concern is.
We could add a provision, Ralph, here that just says that if a citizen or employee appears before the board and identifies a complaint, that will be referred to the administration to address. I mean, that's consistent with what you're doing now.
Right.
And I can just add that. Okay.
This is Zim. Typically, the chairman takes on that mantle, at least in the boards that I've been on in the city council, where the chairman would direct the staff and say, so-and-so, please get with this gentleman or this lady and follow up on their concerns.
Yeah, I agree. I don't think there's ever been an instance in which we've told someone to have a nice day and there's no follow up to them. I can't remember an instance. If we need to codify that, that's an easy fix in item 2B, and we can say that the chair will direct staff to look into whatever issue. I don't know how we say that, Neil, but
Yeah, I'll come up. I mean, it'll be considered what you're doing now.
okay.
And while we're in that section, item 6, where you talk
2B.
about still in the same section, where it says 3 or more persons sign up to address the board. How in the world do you limit discussion on a single topic to just 9 minutes?
This is, we actually, I believe, I thought we expanded that a little bit. It went from 2 minutes to 9 minutes.
Yeah.
If I remember correctly.
You've gone from 2 minutes to 3 minutes per person.
Correct.
And then if it's the people that speak get together and appoint one spokesman, you go to 10 minutes. That's not my point. My point is you can have 30 people in the room, and if you only address 3 or 1 of them, there are going to be some unhappy folks, and we are appointed from an electoral board to listen to and respond to our citizens. And I don't see how you can just say, if it's a subject that they're really interested in, I'm sorry, 3 of you can speak, nobody else can, and get away with it.
The Open Meetings Act and AG opinions interpreting that language says that the governing body can set a reasonable time. It doesn't dictate how long it is, but it also, there are provisions in some AG opinions that says the governing body has the authority, if there are multiple people speaking on the same topic, that they select a spokesman to speak in their behalf. That's permissible under the statute and the AG opinions interpreting that statute.
Yeah.
I understand.
It comes back to whatever this governing board chooses to do.
Yeah.
Go ahead, Sam. I'll wait for you.
I understand what the guidelines from somewhere else are, but the reality is, if you've got an issue that's a hot topic, I'll just give you the city council. You know, you're talking about the police issues and whatnot. If we limited it to 3 people speaking or 1 speaking to 3, there'd be riots in that council meeting during the meeting. Everybody that wants to should be allowed to speak.
So I think in the language that does, because it states the board may encourage the persons to select a spokesman, but it's not something where we're saying within the procedures that on this topic, only 1 person can talk on a single issue.
And there's nothing in the writing that excludes anybody from speaking.
Yes, there is. It says that no more than 9 minutes will be allowed to any subject or any topic.
Well, that may, I agree with them. We can change that particular one and just put it in clear language that if they decide to speak as a group, then they would receive the 9 minutes, but not 2.
But you are not saying that they only have 1 group that can speak. That is what Zim is saying. What if you have 30 people to show up and you're saying 10 people can come as a group, but you're not limiting it to 1 group. Am I understanding that correct? If 30 people show up to speak, and maybe there would be 10 of them that wanted to go as a group, are you saying that the other 20 couldn't speak? I mean, I think a lot
of that comes to the purview of the chair of the particular meeting. The I think are good guidelines for people when they come to speak, to have their arguments written, well thought out, whatever else. If we don't have a limit, we could have this meeting for 3 days and listen to everybody. The whole idea of rewarding them for speaking as a group is 50 people can, have the same thought. One person can present those thoughts.
And just to point out that 9 minutes is existing policy.
Yes. Yeah. This isn't.
I don't object to changing it.
Yeah, that's not radical changes in this instance, but I think a reasonable amount of time to let anyone speak is fine. I think having no limits to speak could mean some very long days. I don't think that even with current policy, when people have come on controversial topics, I don't ever remember us keeping a clock, but we are here to codify it. So
Yeah, we keep a clock, excuse me.
According to your bylaws, y'all can't debate this anymore.
So, but the other thing I would point out here is it says the board may encourage the person to select a spokesperson. Again, you're encouraging them to be efficient in their presentation. It's not that you're mandating it.
My problem is still a line that says no more than 9 minutes shall be allotted for any single topic. That's the part I got.
Would it be better if it was not 9 minutes for any allotted speaker?
No, you got the right thing with the 3 minutes per person, or 10 minutes if a group gets together and appoints somebody. And it doesn't matter whether it's 3 people or 20 people that one person is speaking for. The problem is if you're setting up a situation where after 9 minutes, or actually it would be 10 for if a person representing more than one, subject's over. And that's dangerous from the standpoint of the kind of body that we are, and we're supposed to be representing the citizens in working with the JPS. And it just seems to me that the minute you put that in there, it's a defining thing.
Yeah. And
it just shouldn't be there. That line should not be there at all. Everybody that should speak in front of us should be able to.
Okay. Should there be a time limit on the amount of time to come and speak to us? 30 minutes, an hour?
Hopefully we're not like a city council where you get these barn burner issues. Sure. I don't know why you would do that. And typically what would happen is with the mayor or with the chairman, he would encourage people, if you've already heard somebody make your point of view, please pass when we call your name. There's all sorts of ways you can try and shortcut it.
Right.
But just to put in there 9 minutes and it's over is not a good thing. I'm beginning to sound like Steve now.
I would agree with them, though. That's a really good point. I'm for striking the line completely.
Yeah, I agree. I agree, Zim.
Okay, so tell me where it starts and stops. In any event, no more than 9 minutes should be allowed for any single topic.
Yeah.
Strike that line completely. Okay. What about if the person speaks for the group 10 minutes?
That's good.
Okay.
I choose to speak that way. Yeah.
All right. Then we can strike that line. And I'm trying to write this down so we can consolidate this into some kind of motion to move forward. This is
I've made Mr. Chairman, as we made these, I've made a note in here in terms of what we need to update.
Okay.
So, and you'll have another chance to look at them between now and the board meeting.
Can I have a spoiler? Be a spoiler here?
No, DT, you may not.
Let's say let's say we budget it for 2 hours. Should we give it a consideration how much we would allow? Because you can sit in there for 10 hours, or somebody may leave and you don't have a quorum. What happened?
You just don't have a quorum.
Yeah.
then it's automatically stopped, or how does that work?
The
board can't, whatever number of board members are there that's less than a quorum, cannot take any action, and the chair can choose to continue the meeting or continue to receive input.
Because if
It's up to the chair.
2 or 3 hours and we have other obligations after that, so if this keeps going for 2 or 3 hours, we can have a meeting with no meeting at all.
There's not a limit on that.
So should we do a portion of that, 1/3, quarter of the time, or maximum half of the expected agenda is the time allotted?
I don't think you can formally do that, DT. I think it goes back to what Zim said earlier is the chair encouraging the group to confine their comments and respect other people's time and hope that they listen to that. But beyond that, I don't think you can restrict it.
DT, you're not getting paid by the hour, so what's your problem?
No, because I'm more concerned is that you may have some medical professional people in the room, and they may have to tend to that patient. And if it's continue, you will never be able to get to hear what's on the agenda. That's all I'm saying. I'm just
practically, I can remember maybe, Robert, at least maybe only 2 meetings where we've had a huge crowd.
Yeah.
And the chair admonished the group, or not admonished, but suggested to the group that they get out in the hall and select spokesmen. And there were like 3 or 4 groups, and they got out and selected 3 or 4 spokesmen, and it went fine. I think people generally will respect time if you ask them and give them an opportunity for their group to be heard.
Neil, does the Texas Open Meetings Act allow limits on public speech?
It says something to the effect that there's some opinions on interpreting that, but it says a reasonable time. It doesn't say a specific time. It says a reasonable time. Again, I think that comes back to the suggestion from the chair each time in terms of respecting people's and the staff and everyone's time. You have to be given a reasonable opportunity to be heard.
But I mean, if we said public input is capped at 2 hours,
I don't think you can do that.
Okay.
My question, now that I've chewed on this a little bit, when do these citizens get to speak on a specific agenda item? Is it still at the beginning of the meeting?
Yes. Again, that's up to the governing board. There's some governing boards that allow it at the time of each time an agenda item comes up. But our policies dictate, which is permissible under the Open Meetings Act, that if a citizen has an item they want to speak to on the agenda, they do it at the first of the meeting, and they have to sign in and identify what topic they're speaking on.
And when we do that, then do we move that agenda item up?
Only from the standpoint of receiving their input.
Well, see, then I guess I've got a problem with that too, because it would give the citizen the opinion, okay, we've heard from you, go away, and we're going to do whatever we want to go do. They need to make their comments when the agenda item comes up. That's the way almost.
That's not been the policy of this board.
I understand that.
And Zim, I wouldn't encourage that, because that's taking the governance of the meeting completely out of the hands of the chairperson, who's there to run the meeting.
How does that work? That it takes it out of his hands. That's the way we do it on the city council.
Well, you could have each individual item come up and have a public forum for each individual item. And then if we have a policy that says, Susie Q wants to talk about item Z on the agenda, that becomes the first thing you talk about.
No, what I'm saying is, to me, the people that speak at the beginning of the meeting would be speaking like we have people that speak at the end of the meeting on the Fort Worth City Council about something that's a burr under their saddle or a complaint or whatnot. It has nothing to do with the agenda at hand. But if it's an agenda item, the people sign up, they sign up for a specific item. And when we get to that point on the agenda, we go through the discussion, and then the chairman calls on those people to come speak on that agenda item.
Well, I mean, either way, it's getting taken care of if they speak at the beginning of the meeting or at the beginning of the agenda item. In some cases, that's, you know, you force somebody to sit there for 5 hours before you talk about the particular item.
It's a perception item, Roger. I don't care which way you do it. I'm just saying, if I come in and I've got a burning bush and it's the last item on the agenda, then if I speak at the beginning, I don't know whether that's taken into account or not. It's just me. So
yeah.
No, Zim,
I'll hush.
Roger, Roger, it's not just Zim. It makes sense that if it's the last item, I spend 5 hours waiting for it, then I would be able to speak and I would hear the results of that action. That's what he's saying. And I agree with that, because I don't think it's going to take any more time if they want to sit and wait, if they're way down on the agenda, and for them to go first. I just think that if you have an item on the agenda, to me, you should speak when that item come up. And then you would be able to hear the board's discussion and vote. And that person would not have wasted their whole time to not know what's going to happen. Okay? That's what I see.
I agree with you.
We have this straight. Zim Zimmerman has echoed the words of Steve Montgomery, and he's agreeing with Dorothy. Just saying, for the record, let's put that.
Well, I think either way, whether they speak at the beginning of the meeting in regards to an agenda item, or they speak prior to any action being taken on a particular agenda item, we're not taking away the public's ability to speak and be heard. And I don't know that we need to codify that in a standard operating procedure document. I suppose if there's a hot issue, and because typically somebody's coming for one issue, not for, 3 or 4 issues on the agenda, it could be the latitude of the chair to say, we'll move up item 3B and vote on it next, instead of, waiting to the end of the meeting. Either way, the public has the opportunity to say their piece about an agenda item, and one way or the other, they have the ability to watch the action of the board, whether they watch it live and in person or they watch it live at home or on YouTube. They have the ability to see the deliberations and the final results of that action. And I don't know that it needs to be codified, to be honest with you.
So I don't have the bylaws in front of me. I'm not seeing where that would be part of the standard operating procedures. I agree with them, Dorothy and Steve, on the fact that it makes sense to be able to look at those items at the time that we're deliberating those items on the agenda. But is it the duties of the chair within the bylaw to make that determination, or is it?
Well, it's the duty of the chair to preside over the meeting, and if they're going to move something on the agenda, they usually ask if there's anybody objecting. Does anybody on the board object to them moving that out of order? And then if somebody does, then typically it stays where it is. That's also Robert's Rules of Order, which the bylaws says that you're controlled by Robert's Rules.
Just to clarify, I'm not opposed to the way it's written. I'm agreeing with Roger on this. So.
Oh my God.
I know. This is a confusing meeting.
Neener. We have entered the twilight.
I don't understand what's happening now. This has got to be related.
Yeah, this is Reverend Emerson. I was going to really somewhat agree with Amanda and Neil. Just in all past meetings in both Zim and our experience with city council, it really, I think we just leave it in the purview of the chairman to distinguish that and determine if he needs to move an item up, and especially we need to be on guard and be knowledgeable, cognizant of the way situations are now, persons attending public meetings, we never know when a time's going to come when they're going to storm JPS board meeting to raise issues about us. And I think we just have to be community friendly, work with them to move the item to a spot, or even be willing to listen to them. I'm thankful that we haven't been hit yet, but I believe it's on its way. So,
Agreed.
Well, and Reverend Emerson, I appreciate your thoughts, and some of that too is we have the rules and these procedures in place prior to any of that happening,
right,
so that we can maintain control of the meetings and the deliberations at hand.
right.
So are we okay if we leave, I've lost the number, item 2A at the purview of the chair? If the chair wants to move discussion, or offer the public discussion and then move that item up to vote, the chair may do so. Or do we want to give everybody an opportunity at each individual agenda item to speak? I can tell you that I tend to leave it to the purview of the chair as we have it standing now.
So
I agree. So would I.
I agree.
Okay. I think that is a majority on that one, so we'll leave that alone unless there's somebody else hiding I can't see.
Well, I just was asking a question. As it's written, it's only at the beginning. So I don't see that chair's discretion. That's
the chair's discretion lies in Robert's rules of
Robert's
the way
rules.
that we've operated. So,
Which the bylaws say you have to operate under, unless
okay.
you.
All right. All right. So your rules is so you okay. All right.
You're not referencing to Robert Early's rule, right?
Not Robert Early.
Sure, it's clarified.
Things that get done a lot faster around here. DT, thank you. Is there any other discussion? Any other particular verbs that we need to discuss?
I have a question around number 3, voting. 3B.
3B, okay.
I certainly understand that you remove yourself from that. But you have to vote. What if you don't have enough information and you're not providing enough information and you don't want to vote no, but you don't want to vote for it?
It's your obligation. It's your obligation as a board member and a fiduciary responsibility under the law to identify that you don't have that. And then if the majority of the board wishes to proceed, then your vote is an abstention.
Yeah. Yeah. So yeah, you can abstain. I would hope that if you didn't have enough information, you would vote no. But you can abstaining is a vote option.
It's still an option, right? Okay, just want to make sure it's still an option.
Yep.
It is.
Any other comments?
Roger, back to the first one that Steve was talking about under A1.
Yes, sir.
The same language is in number 4 that will need to be changed as we go down the line as well.
Oh, the review and final approval language.
Yeah, and the general counsel office that we.
Yeah. Okay. I got it.
When it comes time for final approval.
Okay.
Gotcha.
Got it.
Okay, let me see if I can consolidate this into a motion, and if it's right, that'll be very lucky.
I'd like to have 10 minutes to speak on this topic.
Sorry, sir, your time is up.
Mr. Weber, you can speak for me. So
let me see if I guess before I make a motion, let me summarize the changes that I've written down. A1, we should remove final approval and change that for review. Same with item A4. We'll make a note to the footnote that the past chair is a non-voting member of the executive committee.
Mm-hmm.
Item B2, we're changing insure to insure, E-N. We're changing chair pro tem instead of chair pro term. In 9B, section 2, item B. Oh, God.
Taking out ETC.
Yeah, we're moving et cetera, et cetera, et cetera.
That's the Montgomery Amendment.
The Montgomery Amendment. Is that what? It's 9B, but what section?
It's in B. It's at the very
Nine,
9B.
section 9, paragraph
Roman
B.
numeral 9B at the very last line.
9B, last line. Okay.
The ETC.
And then in section 2B, we'll say that the chair will direct. Let me get back to that. The chair will direct the appropriate staff member to resolve any public.
Yeah, I got that. Yeah.
All right.
Roger,
And then,
can I make a comment about what you just said?
Sure.
I don't know that we should be directing to the staff member. I think what we should be doing
Ought to be the CEO.
The CEO.
President,
Yeah.
drafted. President CEO is what I've got drafted.
Yeah.
Yeah. Not the staff member. That
right.
Yeah.
Okay.
And then item number 2A, number 6, we're striking the line, in any event, no more than 9 minutes shall be allotted for a single topic.
I've got that.
Was there anything else?
Yeah, there's one more. Go back to, this again is the Montgomery Amendment. This is item 1, Roman number 1, B2, the 72 hours. I'm going to modify that paragraph B2 to make sure that's, the board members have that within 72 hours. Yeah, okay. Clean that language up, which I think is consistent with what we're doing now. When we post it, you got access to it immediately.
Yeah.
So,
okay. Is everybody
that
clear on those proposed changes? I hear that everybody sounds clear. Given that, I will ask for a motion to approve the amended standard operating procedures with the changes as outlined previously.
I have one more one.
I got a move for approval from Amanda. A second.
DT had a question.
DT, you have to speak up.
Item 8.
8. Roman numeral 8.
I can't hear DT.
I know we have 8B. Check out the
DT 8, Roman numeral number 8. B. D. D.
D as in dog.
B as in boy. B as in boy.
D as in boy.
8B.
Boy dog.
8B. Question.
Etc.
DT, how can you be so silent? I don't understand.
I don't understand either.
Where'd it go?
Hold on.
Can you hear me now?
Oh, yes.
Yay.
Yeah, 8B at toward the end. Is it administrative issue, comma, etc.? Did we take that one out yet?
Yes.
We took the ETC out. Yeah.
Yes.
That's the Montgomery Amendment.
That's the Montgomery Amendment.
Yeah. Actually,
Got 2 places, right?
Okay.
Okay. I believe I have a motion by Amanda. Is that true? I am looking for a second.
Second.
Second by Mr. Montgomery. Anybody opposed to the changes and the passage of the standard operating procedures? Hearing none, I declare that that is passed.
That's a victory.
Thank you all. Can't wait for. Okay, if you're not speaking, if you can mute, that'd be awesome. And I might ask can we close the screen? I guess we need, never mind. It makes it easier to mute whenever the toolbar's up there. But anyway, Ron, what's next? I've lost all control here. Oh, item number two.
Item number two. Yes.
Now let's talk about the compliance program reports and updates.
All right. I don't have to mention to anybody of all the changes that have taken place just in general since we last met. And so there's no different for compliance. Compliance issues across the board have increased. And I've picked out 4 items here that represent some things that are happening in the industry, but also things that we need to always keep an eye on as well. Jeffrey, you can move the next slide, please. This first item kind of goes hand in hand with what David spoke about in terms of cybersecurity. The Department of Health and Human Services, in tracking breaches, has noted a 50% increase in cybersecurity breaches compared to this time last year for some of the reasons that David had mentioned. So some of the things that they talked about were specifically in healthcare were breaches where hackers were trying to access medical devices, particularly around the telehealth arena that were unsecured or unencrypted, as well as trying to continue to try to get PHI for financial gain. And so PHI is not a new issue, but certainly the hacking of medical devices, as well as trying to breach or do social engineering for communications among healthcare providers and patients has increased quite a bit. Hence the reason why cybersecurity should continue to be an ERM risk. The second item is out of Arizona. It related to a fraud related specifically to the COVID pandemic. This fraud basically was committed by a healthcare entity that was essentially offering free COVID testing if patients filled out this whole body assessment, and then the patients would fill out the assessment, and then they would bill for services that were not medically necessary, completely unrelated to COVID. And it doesn't say what the dollar amount was, but there were quite a bit of fraud related to that. And then the third item, it says Dallas, but actually it's Fort Worth. It's a little more closer to home. There's a pharmacy provider, compound pharmacy here in Fort Worth, RX Express and Express Compounding. They're a compounding pharmacy. And this is an allegation, but there was an indictment for the 6 pharmacy owners for allegedly receiving $14 million in kickback schemes. So they were essentially engaged in a scheme where they were referring TRICARE and Department of Labor beneficiaries for expensive compound drugs, and then charging them back without medical necessity. And obviously, many of these are veterans or military personnel over a long period of time. Again, this is an indictment, but it also sparks the risk profile, particularly of compound pharmacies. We've talked about that a little bit. I know we don't do compounding at JPS, but it's a relatively close to home item, which why it made the list. And then the last one is the Texas Department of State Health Services. Actually, it's not MHMR; it's the Department of Aging and Disability Services, where that's an agency that recently moved under the Texas State Health Services, and they essentially, this was a mistake on their part. They had a database of patient information that had a little over 6,600 patients in it. It was on a private server, and they in error moved it to a public server to where it was available for viewing on the internet. That had people's names and addresses and social security numbers and all kinds of private information, which obviously was a breach. OCR, had fined them a $1.6 million civil monetary penalty as a result of that mistake that was made. So again, a continued vigilance is necessary, even more so, I would say, during this period of time, because unfortunately, people who try to take advantage of the system don't take a break given during this period of time. So those are the compliance headlines. I want to move to the next slide, Jeffrey. A quick update on our conflict of interest disclosure process. So as all of you know, we do this every year. And one of the things that we strive to do is to make this as clean of a process each year as possible. This year, we had a little over almost 1,300 leaders and practitioners who were issued the survey. It was due on April the 15th, and as of June the 8th, 92% of those had submitted their survey, their conflict of interest survey. And we also linked disclosures, particularly for physicians, to the Sunshine Act open payments database. And so, as you see in the chart, company 100 as a review is JPS. And so we had 100% compliance from JPS as of that date. Company 600 are vendors, consultants, contractors is what company 600. So as of the 8th, we have 94. And then company 900 is Acclaim, which is primarily physicians and practitioners. I will say, because I anticipated a question on this slide, that as of today, this morning, we reran the number, and Acclaim only has 8 outstanding as of this morning, and found out that 2 of them had extenuating circumstances, so that leaves 6. And in talking with the claim management, they indicated that their policy now is not to allow physicians, those 6, access until they complete their COI disclosures. So I know that probably was going to be a question as well. Yeah, which is a very strong move. And we also are down to 90 on the vendors and contractor side. So we still have a little bit of work to do there. But and then the piece that you may not be aware of is that on the last line of the slide, the number of respondent disclosures, those are people who answered yes to one of those 13 questions that were asked as a part of the disclosure. And so those, for example, in company 100 JPS, there's 38 individuals that answered yes. That does not necessarily mean that that's a problem. That just means that they had something to disclose. And so we just would need to go through our process and the follow-up to determine whether or not there's any follow-up that's needed. So that's all a part of the process. So any questions on that before I move on?
Ron, that includes all full-time, part-time, independent contractors as well, correct?
In company 600?
Okay, in 6 and 9. Well, at total overall.
Oh, the total overall. That includes, that does include contractors. That's
contractors.
Correct.
Mm-hmm. Yeah. So what we were talking about earlier are maybe once a month physicians or anybody else they're included in those disclosures.
Well, that's a good question, because this has been an issue for a little while. Kind of get my echo. So one of the things that we decided to do was for locums physicians that aren't here but maybe once every so often. They in past years were on the list, but in looking through best practices and looking at what others are doing around this, those probably should not be receiving these disclosures in the first place. And so unless Michelle corrects me, I believe the 1283 that received, or actually the 571 did not include locums. Is that correct, Michelle? That's not true? Oh, they're not. Okay, the amount of time that they worked was the trigger. Can you elaborate on that?
Yes. So there was a classification by Med Staff Affairs in terms of the number of hours worked in a given year, and that's the trigger that we use, that status, not whether or not they were locums, because we have locums that can be full time, quite a bit of full time. So that was not the trigger. It was a classification.
Okay. Any other questions on conflict of interest?
Anybody out there in the universe?
All right. Hearing none, we'll keep moving. Next slide, Jeffrey. So I'll have Michelle to give an update on our overall compliance audit work plan status.
Thank you. I wanted to give the board a sense of what was on the horizon in terms of the compliance audits. You can see the top three. We're going to have a conversation about those very soon. The radiation oncology billing is underway, as well as contract pharmacies. And so what we've done is we've taken the contract pharmacies out of the 340B work plan and moved them here so you can have some visibility into those. We do have 162 contract pharmacies, so it's really important that we stay abreast of 340B compliance in that area. And we're looking at really great ways in which we can audit that holistically instead of on a sampling basis. The HIPAA mock follow-up is really an Office for Civil Rights follow-up review on the 3 HIPAA rules. That's privacy, security, and breach notification. And as David mentioned earlier, we have a new CISO. And so we're really looking forward to seeing some great changes that have happened since we last looked at that. The last one is evaluation and management. We're just going to look at the charging, the changes that we've made in the community health center, and the interventions that make up a certain level that's charged. And so we're going to take a look at that for consistency. And that will be starting here, all of this again before the end of the fiscal year. Next slide. Real quick, I forgot to mention too, we discussed at the last meeting that I would put the ethics point cases on the board portal on a quarterly basis. So just wanted to remind you that that is out there. We didn't have anything glaring or unusual. We have typically about the same number of cases a month, about 10. And so you should find that on your board portal. This next slide, I wanted to share with you that we've added an additional privacy monitor due to COVID and the sensitive nature of that. And so it says here as of the 9th of June, we had 600 positive patients in our system, in our Epic system. As of today, it has grown to 814. And so what we've done is we have a software program called Maze that does some smart monitoring of those medical records for appropriate access. And so what it does is it flags us if it seems to say, and it's looking for clinical appropriateness, and it'll flag us, and then we have to go in and manually do some investigating on that area. Again, this monitoring takes place behind the scenes. And what I mean by that is, as opposed to break the glass, which you probably remember and heard of quite a bit, we started to apply break the glass automatically if you are an employee. Break the glass requires you to re-enter your password and to enter a drop-down reason as to why you're going to enter a patient's record. So we did not, of course, put that on the COVID patients. You know, it is quite a nuisance to have to go in and continue to do that if you're in a clinical care space. So just wanted to let you know, those are some additional privacy access monitoring that we started as a result of COVID. We also have the data loss prevention and protection that David mentioned earlier, where anybody that sends emails out to, typically what's happening is they're sending it to their own personal email accounts, Gmail accounts and whatnot. And so we have a privacy official that contacts, the individuals and notifies them that they need to delete those emails and make them understand that they actually have violated some policies, and we send those policies that they have violated. So what I need to do now, before I turn this over to Tim for a status update, is we have to share equipment. So I am going to unplug and let him take over.
While they're doing that, are there any questions on our privacy monitoring?
I have a quick question regarding to COVID-19 around the contact tracing. Whether on the line with HIPAA and contact tracing and all that stuff for the spread of it.
DT's questions regarding HIPAA and contact tracing and how we fit in compliance with that.
I'm going to have to defer that to contact tracing.
That's not that's not a HIPAA monitor that we currently do. I know that is from a COVID standpoint, that would be a protocol that the COVID task force would be responsible for. We can certainly take that back. I don't know if there's anybody here that could speak to that, but is your question, to make sure I can understand, is your question, how are we doing contact tracing for COVID positive patients?
No, yes. And the other question is around how do we protect patient privacy around that? And it can be uncharted territory here. Just want to make sure that whatever we follow doesn't get out of hand.
Okay.
Get us in trouble.
Okay, good question. I will take that as a follow-up with Dr. Duncan and the team, and we'll get back with you. Tim.
I don't see Tim.
Want to hear me? No? How about now?
Now I got you.
Got it? Okay, great. All right, next slide, Jeffrey, please. Okay, well, we are well past the halfway point during our fiscal year and wanted to give you an update on our audit plan for FY20, where we are, what's left remaining, and some other updates as well down at the bottom. So just starting at the top here, you may remember back at the February meeting, we briefed the 340B modified mock HRSA audit. That was an audit that was performed by 340B experts from Crow. So that's complete. And the next one on contract financial tracking, that is complete as well, and we'll actually be speaking about that in just a little bit here. Transitions of care, this was an audit where we worked closely with Dina and the care management team. That audit is complete, completed about a month or two ago. However, because the large volume of materials we had at this meeting here today, we'll be briefing that to you all at the next meeting in August. And then currently we're in the middle of a biomedical devices audit, working closely with David Mendenhall and his team from clinical engineering, particularly Jewel Newell and her team. And then the last audit that was on the plan, number 5, provider credentialing. We are just in the early planning phases for that now, talking to Dr. Elliott, Cindy Radcliffe, and we'll be getting started on that within probably the next month or so as far as planning. Number 6 here, external quality assessments. We're pretty excited about this. This is actually an external firm coming in to evaluate our processes. So the internal audit department is getting an audit ourselves. And they're gonna compare us to best practices from some of the best internal audit departments around. And this is also something that's recommended from our organization, the Institute of Internal Auditors, every 3 years, actually. And JPS's internal audit department has actually never had an external quality assessment, so this will be the first one. And so we're excited to learn about, what are we doing well and where do we have room for improvement also. So that actually just finished the contracting phase, executed the contract, and they will be in, I think the August timeframe is when they'll be in, and actually be on the lookout as well, because they will also be interviewing members of the board about the internal audit function and your thoughts, as well as members of senior management as part of the review.
So we're auditing the auditors.
Auditing the auditors, that's right.
And the sad part is, and I love internal audit and compliance, but they're excited about it.
Little nervous. Hopefully it's good results.
We've heard a lot of crazy stuff today, and the stars are aligning, but internal audit is excited about their own audit. But I wanted to point out, especially to Ms. Dorothy, that you can see here where many of these audits that are completed are part of that co-source that we approved at the last meeting. You got to think about all the work that's happened between internal audit. That's internal audit is 3 people and compliance is 5. So it's a very small department doing a very, very large amount of work. And I just want to make sure that's in regards to the item we passed last meeting. This is what it goes for.
And I would add to that, the Crow and KPMG agreements, which is different this year than they had been in the past, is that in the past, Crow had just been an internal audit co-source, but this is both compliance and internal audit. So the amount that we have in our contract is split between both functions, and so they'll be doing compliance projects as well.
May I ask a quick question? When you credentialing, are you credentialing? What type of credentialing are you guys doing? Is that something that we can also use when, let's say in the future, we're signing up with a Medicare Advantage plan or some other accountable care or whatever the value plan, insurance plan that we sign, and they go to a credentialing if we take full risk and all that stuff? Is that the same thing, or we have to go through the whole thing over again? And do you guys coordinate with them so that when things are out of bounds, you know what to audit them for?
So at this point, and we're still very early in developing our scope and objectives for that last audit around provider credentialing. But where we're headed right now is really focusing on the medical staff services department and getting our providers going through the credentialing process for them, and also set up with the third-party payers as well. But if you have some thoughts, DT, around maybe some areas outside of that we should consider as part of our scope, because again, we're really early right now, and depending on the risks that are out there, have opportunity to add potentially add stuff into scope. Definitely open to suggestions.
Yeah, it's going to be something that you may want to coordinate with our CFO and the contract team, because what I feel is doing one what we can use multiple times later on, so that every time they sign a contract, they have a period they can declare opt-out period, so that everything opt-in. That way we don't have to go through all that extended period and cost to do that down the road for those contracts.
Great, thank you. I'll definitely coordinate with finance about that, DT. Thanks. And the only other thing that are noted on here that I'll point out, at the next meeting in August, we will be presenting our FY21 audit plan as well for discussion and your approval as well. And then the last thing is, you'll see a footnote there about construction oversight. We did have a project on the plan for FY20 around construction, any potential construction projects, but that'll be postponed to align better with future projects going forward. Any questions about status of where we are in our plan or anything else?
Sounds like good work.
Yeah, they're doing very good work with very few people. It's impressive.
Thank you.
All right. Yeah. DT, that's funny. I couldn't hear you all day, but I heard that loud and clear. So we will adjourn here now. Tim, thank you. Michelle, thank you. We will adjourn at 1:33 to a closed session.
Thanks.
Hit it. All right, with no further business of the governance committee, we stand adjourned at 2:39. Thank you all.
All right.